Pardon? Yeah. Welcome you all to another session of the Clinical Neurology Forum. Today we have cases being presented from Coimbatore Medical College Neurology Department. Professor Shobana, HOD, will be the moderator. And we have Professor Alagason from Tirunelveli Medical College. Of course, now he has retired. And he will be the chairperson for this session. I hand you over to Alagason, sir, to conduct the proceedings. Over to Dr. Alagason, please. Sir,
Yes, sir. Yeah. So, good morning to all. It's both an honor and pleasure to chair this 15th Clinical Neurology Forum, which is a remarkable forum that has enriched our clinical learning neurology by thought-provoking discussion and academic exchange. I wholeheartedly thank Professor V.N. sir, who is my teacher, mentor, whose tireless effect, passion for teaching, and the consistent mentorship practice that has elevated this forum to 15th milestone. So I also appreciate faculties of Department of Neurology, Coimbatore Medical College, particularly Shobana Madam, for presenting these 5 interesting cases. So we'll start the session. First case, I request Dr. Sangavi to present a case of ataxia for diagnosis.
Yes, sir.
The Sangavi.
Okay. Is my screen visible, sir?
It comes and goes.
Yeah, 1 second. Yes.
Yes, please.
A very good morning, everyone. I'll be presenting a case of ataxia with diagnostic dilemma. So moving on to the demographic details, Mr. X, he was a 54-year-old male, resident of Coimbatore, and he studied up to 8th standard, right-handed individual, employed as security, informant as self and his son, and the history is reliable. Patient has come with the chief complaints of urinary disturbance for the past 2 years and burning sensation of both feet for the past 1.5 years, unsteadiness of gait for the past 1 year, and slurring of speech for the past 11 months. So moving on to the presenting illness, patient was apparently normal 2 years back. Then he noticed urinary disturbance in the form of increased frequency. That is, he has to walk 12 to 15 times during daytime and 6 to 7 times during night. And however, the patient was able to perceive the sensation of bladder, but he often experiences urgency, and there were multiple instances of urge incontinence. When he tries to ward, he had difficulty in initiating the strain of micturition. So he had hesitancy. However, the urinary stream was normal, but he also had a sense of incomplete evacuation. And the symptoms were insidious in onset and gradually progressive. However, the symptom was not associated with any dysuria, loin pain, or hematuria. No history of any bowel disturbance. And it was also associated with erectile dysfunction for the past 2 years and absent nocturnal tumescence for the past 2 years. No history of any skin dryness or color change. No history of abnormal sweating or palpitations or blackouts. No history of any postural giddiness. There was a history of burning sensation of both feet for the past 1.5 years, which was symmetrical in onset, and it was restricted to soles of both feet. No history of any numbness or cotton wool sensation. Patient was able to perceive the clothings all over the body, and he was able to perceive hot and cold water while taking bath, and he was able to perceive mosquito bite. No history of any spontaneous ulcers or skin changes. There was a history of unsteadiness while walking for the past 1 year, which was insidious in onset and gradually progressive. In the form of, he had a tendency to sway towards either side while walking, and the imbalance was more with eyes open. And he had difficulty in negotiating through narrow pathway. It was not associated with any clumsiness or tremulousness of hand, no history of head nodding, no history of spillage of food or water while he's eating. There was history of slurring of speech for the past 11 months, such that attenders had difficulty in understanding.
2 minutes, actually.
Such that attenders had difficulty in understanding the spoken language. However, patient is responding promptly to the bystander's comments, and he was able to name and repeat. And it was not associated with any undue straining or individual stressing of syllables. No history of any explosive quality or hoarseness of voice. No history of nasal twang to the speech. No history of slowness of activity or stiffness or abnormal posturing. No history of falls or any upper and lower limb weakness. No history of stiffness, flailness, or twitching or thinning of muscles. There was history of decreased sensation of smells since childhood. No history of blurring of vision. Patient was able to perceive the colors. No history of double vision, and he was able to perceive the sensation of face, and he was able to chew well. He was able to frown and close the eyes tightly. No history of deviation of angle of the mouth, and he was able to perceive the taste sensation correctly. No history of hardness of hearing, tinnitus, or vertigo. No history of hoarseness or nasal regurgitation, and he was able to marshal the foot. No, he was able to shrug the shoulders properly and turn the head on either side. No history of any memory or behavioral disturbance. No history of headache or vomiting or seizure episode. No history of trauma, radiation exposure, weight loss, or fever. So moving on to the past history, there was history of migrainous headache during childhood, and he has taken anti-migraine prophylaxis. However, the patient is in remission for the past 6 years without any treatment. And after admission, patient was diagnosed to have valvular heart disease, probably of rheumatic etiology, with AML, PML thickened with mild MS and MR. He was not a known case of diabetic or hypertensive, old PTB, thyroid, or seizure history. There was history of cataract surgery in both eyes 6 years back. So moving on to the family history. So the proband was 54 years old male, and he was 10th born male child born out of non-consanguineous marriage. However, his 5 of his elder siblings has succumbed in their early phase of life, that is in their early infancy as well as in the first 2 years of life due to some neurological illness, the exact cause of which is not known. Patient is having anosmia since birth. One of his elder sibling is also having anosmia since his childhood. And one of his paternal uncle's son is also having anosmia since childhood. However, none of them had any imbalance history or autonomic disturbance or any erectile dysfunction as per the history. And personal history, he consumes mixed diet, no sexual promiscuous history, is not an alcoholic or smoker. So to summarize, this 54-year-old male presented with insidious onset, gradually progressive neurological illness in the form of urinary disturbance and erectile dysfunction for the past 2 years, burning sensation of both feet for the past 1.5 years, gait ataxia for the past 1 year, and dysarthria for the past 11 months, with history of anosmia since childhood without any motor weakness or higher mental function involvement, with background history of unexplained death in his siblings and anosmia in his family members. So after history, the probable structural localization is, so initially patient had urinary urgency, frequency, urge incontinence, as well as hesitancy. So this localized to, that is involvement of both sympathetic as well as parasympathetic fiber dysfunction, and erectile dysfunction also localizes to parasympathetic dysfunction. So this symptom, we want to take it as autonomic neuropathy. The next symptom was burning sensation of both feet, which was restricted only to the soles. So this we have localized to small fiber peripheral neuropathy. Patient had gait ataxia. The imbalance was more with eyes open, associated with dysarthria. So we have considered it as vermis and paravermis involvement. And anosmia, probably some olfactory nerve involvement. So with the structural localization, we were considering the possible etiologies. So it is a late onset ataxia plus syndrome. So we were considering any possibility of SCA, because the manifestation of SCA could be heterozygous. The autonomic involvement has also been reported in few cases. So we were considering the possibility of SCA followed by mitochondrial. The reason being the multi-axial involvement with early cataract surgery, with migrainous headache, with some cardiac involvement, with unexplained death in his siblings. We were considering any adult onset ataxia because of Pol G mutation, probably MIRAS, that is mitochondrial inherited ataxias. The other being MSAC, early autonomic involvement would be the co-feature along with ataxia. However, even with 2 years of symptom onset, patient had never experienced any falls or any cognitive impairment or Parkinsonism. So that is a feature that is against MSAC. So these were the differentials that we were considering at this junction after history. So moving on to the examination, patient was conscious, cooperative, moderately built and nourished, no pallor, icterus, clubbing or cyanosis, pedal edema, generalized lymphadenopathy, no goiter, and subcutaneous lipoma were noted over the right and left elbow and also over his trunk. No other neurocutaneous markers including tendon xanthomas, no peripheral nerve thickening, height-neck ratio was 12.8. Moving on to the vitals, patient's pulse rate was 84 per minute and it was regular in rhythm, normal volume and character, no radiofemoral delay. And BP was measured after 20 minutes of rest in supine position. It was 130 upon 90 millimeters of mercury. And after 3 minutes of standing, the pulse rate was 88 per minute, and BP has dropped significantly to 98 upon 60 millimeters of mercury. Respiratory rate was 16 per minute. Saturation was 99% in rumor. Patient has studied up to 10 standard. Its MMSE was 29 upon 30. All lobar assessments were normal. So moving on to the cranial nerve examination, olfactory nerve, smell was absent in both nostrils. Other cranial nerve examination, including the fundus, was normal. There was no oculomotor, trochlear, or abducent involvement. Taste sensation was also normal. Bulbar examination was also normal. There was no hearing loss. So moving on to the spinomotor, on inspection, there was no obvious wasting of fasciculation. Palpation, mid-arm circumference, mid-forearm, mid-thigh, and mid-limb circumference, which has been measured on either side, is symmetrical. Tone was normal in all 4 limbs, and power, both upper and lower limb, proximal and distal, was 5/5 on either sides. So superficial reflex, conjunctival reflex was present on both sides. Corneal reflex was present on both sides. Jaw jerk was absent. Gag reflex was present. Abdominal reflex was absent in all quadrants. Cremastic reflex was absent. Both superficial and deep anal reflex was present. Plantar was mute in right side, and it was extensor in left side. So deep tendon reflexes, biceps jerk was 2+ on either side, triceps was 2+, supinator was 2+ on either side, knee reflex was 3+ on either side, ankle reflex was present. All the primitive reflexes were absent. Sensory examination, paresthesia was noted over the soles of both feet. However, the touch, pain, temperature, and all other dermatomes were normal. Joint position sense and vibration was normal, including the spinal vibration. Cortical sensations were intact. Romberg's patient had the tendency to sway even with the eyes open. So moving on to the cerebellum examination, patient does not have any perturbation. There was ill-sustained gaze-evoked nystagmus was noted. Mild dysarthria was noted, but it was not qualifying for a typical scanning or staccato speech. Finger nose test as well as finger nose test was impaired on both sides, more on the left. Rebound was negative. Dysdiadochokinesia was noted more in the left side. No truncal ataxia. Heel shin test was impaired on both sides. Patient had stance ataxia, gait ataxia, and tandem walking was impaired. I would play the video clip of the dysarthria. Chakravarti Rajagopalacharya. British Constitution. British Constitution. Amma solunga. Appa. Gangai, Mangai, Alli, Lilly. So as we could see in the video, patient was able to tell his address correctly. Even for Chakravarti Rajagopalacharya, there was no scanning or any staccato speech. But when the patient has been asked to tell British Constitution, mild slurring was noted. However, other guttural, labial, and lingual components were normal. So this is a video clip demonstrating impaired finger nose test. அதே மாதிரி இந்த கையில விரல தொட்டுட்டு மூக்க நுழைக்கணும். விரல் நுனியை தொட்டுட்டு மூக்க நுழைக்கணும். So patient had mild dysmetria on either side. So this is a video clip demonstrating dysdiadokinesia. இந்த கையில பண்ணுங்க. So dysdiadokinesia was more in the left side. So this is impaired tandem walking. So patient had a tendency to sway towards either side while walking. So patient had the tendency to sway even with the eyes open. However, he was able to keep his feet apart from each other. So extrapyramidal system, there was only mild hypomimic phases was noted. Blink rate was normal. There was no axial or cogwheel rigidity, no bradykinesia. So moving on to the autonomic nervous system examination. So the pulse rate, resting pulse rate, which has been measured in the supine position after 20 minutes of rest, is 84 per minute, and BP was 130 upon 90 millimeters of mercury. In sitting position, the resting pulse rate was 88 per minute, and it was 110 upon 80 millimeters of mercury. Upon standing, immediately after standing, the pulse rate was 83 per minute, and BP was 100 upon 70. After 1 minute of standing, the pulse rate was 88, and BP has fallen drastically to 98 upon 70. After 3 minutes, the pulse rate was 84, and BP was 98 upon 60 millimeters of mercury. So there is a significant systolic as well as diastolic BP drop after 3 minutes of standing. After 5 minutes, the pulse rate was 82 per minute, and BP was 110 upon 70 millimeters of mercury. So we have proceeded with other autonomic tests. When we have performed the Cole-Prasad test, the pulse rate was 86 per minute, and there was no significant systolic BP increment. BP was only 110 upon 90 millimeters of mercury. On performing mental arithmetic test, pulse rate was 84 per minute, and BP was 126 upon 84 millimeters of mercury. On performing isometric hand grip, there was no significant increase in the diastolic BP as expected. The pulse rate was only 84 per minute, and BP was 132 upon 80 millimeters of mercury. So the heart rate variability upon standing is also impaired, and heart rate variability upon breathing was only 8 per minute. However, there was no abnormal sweating, and pupillary reaction was also normal. So from the autonomic nervous system examination, we have inferred that there is involvement of both sympathetic as well as parasympathetic failure. Sympathetic failure as evidenced by orthostatic hypotension and impaired mental arithmetic as well as isometric hand grip test, and parasympathetic failure as evidenced by there is no significant heart rate variability. So after examination, the structural localization were vermis as evidenced by gait ataxia, right paravermis in view of dysarthria, and bilateral cerebellar hemispheres in view of appendicular ataxia. And we were also, as per the history also, we were thinking in terms of autonomic neuropathy. After examination, it confirms the involvement of autonomic nervous system involvement, and there is also involvement of small fiber neuropathy. So even after the examination, the probable differentials that we have discussed after history is still holding good. That is, we were considering any scar, mitochondrial, MSA. As we discussed, the cons are patient had never experienced falls or any cognitive impairment or any Parkinsonism feature. So with this differentials in mind, we have proceeded with the investigations. Routine investigations were within limits, including BCTC, thyroid profile, and ANA profile were within limits. ECG was heart rate was 84 per minute with normal sinus rhythm. Echo was showing AML and PML thickening with mild MS and MR with EF of 60%, probably of rheumatic etiology. And ultrasound abdomen and pelvis showed post-voidal residual urine of 70 ml with normal prostate size. So we have proceeded with nerve conduction study. The nerve conduction study, routine nerve conduction study, has inferred that there has been a reduced CMAP in both ulnar, right and left ulnar. However, the distal latency and nerve conduction velocity was normal. In the lower limb also, both right and left tibial CMAP was reduced. In both snaps, upper limb as well as in the lower lip, snaps amplitude or reduced. So from this, we have inferred that there is involvement of upper and lower limb sensory and motor axonal polyneuropathy. So we have proceeded with SSR, sympathetic skin response test, and we have done both in upper limb and lower limb, and the wave morphology is normal. It is revealing a classic biphasic pattern. However, the amplitude was in the low normal limits. So we have proceeded with neuroimaging MRI brain with whole spine screening. The MRI brain with whole spine screening has revealed diffuse cerebellar atrophy, including the vermis as well as cerebellar hemisphere. However, the brainstem is normal, including the pons as well as the spinal screening is also normal. So, from this, I would like to enlighten on few case reports and articles that we were pertaining to the differential diagnosis that we are considering. So, as we all know, yes, sir. Okay, sir.
I think before that, shall we have a discussion?
Yes, sir. Yes, sir.
The input from other faculties.
Okay, sir.
First of all, Sankavi, it was a very good presentation. Must
Thank you, sir.
compliment you. It was very good. You presented very neatly and precisely, and
Thank you, sir.
it was very good.
Thank you, sir.
Yes, sir. Alagasan, sir.
Sankavi, in your case, the autonomic
sir.
symptoms started first,
Yes, sir.
followed by peripheral neuropathy,
Yes, sir.
and then he has got cerebellar, pancerebellar involvement.
Yes, sir.
And what about the pyramidal tract involvement in your case?
So pyramidal tract,
One
we
side
could
plantar
able
is-
to elicit.
Plantar is
Yes,
extensor.
sir. Only that sign only we got, sir. Otherwise, reflex was also 2+. It was not very brisk, but there is a doubtful corticospinal tract involvement was also there. However, the tone was normal. So we were considering plus or minus pyramidal tract involvements.
Ma, were the saccades normal, ma? Eye movement?
So saccades were normal, sir. Eye movements were normal. Saccades and
Okay.
pursuits were normal.
Thank you.
So with this clinical findings, what are the possibilities we can think of? Plus the history of congenital anosmia, isn't it?
Yes, sir.
Congenital anosmia and the family history of anosmia is also there, isn't it?
Yes, sir. Family history of anosmia is there, sir.
Right, right.
Family still early deaths also.
So early death is also there. 5 siblings have died, but they are telling it's because of some neurological illness that has happened in their early infancy. However, the exact cause is not known, sir, and they have not been evaluated.
Allegation, she has already listed her differential diagnosis. She has already said it's either SCA, MSA, and probably
Or
mitochondrial. Yeah, these are the things which she has mentioned. Ma, no vestibular dysfunction.
No, sir, no vestibular dysfunction, sir.
Okay. So I think the differential will be the same for, I don't think we can add on to that.
But why early
probably-
death, sir? Why early death in more than
is it-
3-4 people have of the
Chitramalam,
siblings? Yes, sir.
Chitramalam, could it be, I don't know, I'm asking you, could it be related to autonomic system disturbance in them also?
Yes, sir. Yes, sir. Then probably this man has a disease which can manifest in a very early age in childhood in some of the patients and very late in some of the patients. So should we think about those disorders also, sir?
Yes, of course, differential you can. If we
Like,
think that the deaths were
Repsons
due
and
to
Friedreich's
autonomic nervous
ataxia.
system.
Because Repsons and Friedreich's ataxia can have a early onset below 25 years, or it can also have a late onset Friedreich's late onset Repsons. So should we think of, because there is a congenital anosmia history in many of the family members, and 4 of them have died in very early age, must be due to autonomic dysfunction, and they should have also had some neurological disorders, they say. So why not we think about a disorder which can present as early ataxia in some and late ataxia in some?
Okay, sir.
Sankavi,
Yes, sir.
Sankavi,
Like
what did
Repsons?
you make out of the anosmia? How did you fit in with this?
Sir, actually, I'm explaining in the further case reports, and I
Okay,
would like to correlate it, sir.
Okay, fine.
Okay, sir. Okay.
So can it be
So-
due to hereditary sensory autonomic neuropathy?
Uh,
Where
Sir,
we have
how-
combined sympathetic failure, autonomic dysfunction, bladder.
So all these combinations can occur in Repsons also, sir. Peripheral
Sir,
neuropathy, anosmia. Yes, sir.
Yes, sir. Sir, but Repson's disease, usually they will also have associated retinitis pigmentosa and skin
Yes,
will also
Yes,
happen. So that
yes.
is lacking in our case. We were also thinking in that term, sir, but patient was not having, because of the phytanic acid accumulation, they will also have dermatological manifestation and retinitis pigmentosa.
Yes,
So that is not
ATP,
present, sir. Yes.
Yes.
Okay, you can proceed with investigations.
So investigations I have highlighted, sir, there was diffuse cerebellar atrophy was noted. So I would like to quote the relevant case reports that we have, why we have considered the following differential diagnosis. So we all know,
Sankavi,
yes, sir.
Sankavi, sorry for
Yes, sir.
interrupting. There was
Okay,
no changes in the pons.
No,
Because
sir,
we
no changes in
considered
the, yeah, sir,
MSA as-
MSA. Yeah, sir,
we
that is
considered
also
MSA
I
as a
have-
differential.
Yeah,
There
sir.
were no characteristic changes.
No characteristic changes in the brainstem, sir. Brainstem was completely normal. That
Okay.
also I have highlighted, sir.
Okay, go ahead.
Yeah, okay, sir. So as we all know, the cerebellum has many actions, especially in the non-motor functions like cognition, memory, as well as in the language. Recently, the role of cerebellum in autonomic function has also been elucidated. The relevant neuroanatomical substract being, so from the vermis, there'll be the output will come from the vestigial nucleus. This output will go and it will modulate the activity of the hypothalamus, which influences the thermoregulatory system as well as the sexual function. The output from the vestigial nucleus also modulates the autonomic nervous system function, which is present in the brainstem, especially in the pontine micturition center as well as the nucleus tractus solitarius and the parabrachial nucleus. Because of its reciprocal connection with the hypothalamus as well as with this brainstem reticular function, cerebellum plays an important role in the autonomic function, including the cardiovascular, respiratory, genitourinary as well as sexual function. Recently, they have done a meta-analysis which they have tried to unveil the role of cerebellar alterations in autonomic nervous system, of which they have reported in various scars, especially in SCAR3, SCAR2, 1, 6, 7, 17, 31, and 37. So similar to our case, in SCAR3, they have reported autonomic dysfunction as the presenting manifestation of SCAR3. So in which the patient also had erectile dysfunction as the presenting symptom, followed by some urinary disturbance with some mild ataxia, in which they were able to find the genetic correlate of ataxin 3 trinucleotide lipid, and it was consistent with the SCAR3 diagnosis. And another thing is olfactory impairment in familial ataxias. We have also tried to review that literature. The ataxias which can be associated with anosmia, SCAR2, SCAR3, SCAR7, SCAR10, and SCAR38. However, the earliest onset of anosmia in such cases was only in the adolescent. But in our case, the anosmia was quite earlier. So sometimes anosmia cannot be related to any syndrome. It could be just an isolated congenital anosmia, can run in the family. So that were also we were thinking. So other rationale behind thinking the mitochondrial ataxia, suppose if there is nuclear DNA defects, it can alter the respiratory chain function. So in that case, especially if there is a Pol-G mutation ataxias, patient can have both sensory and cerebellar ataxias. So that is the context why we were thinking in terms of mitochondrial also. Especially in mitochondrial recessive ataxias, patient can have mixed sensory and cerebellum associated with migraine. Patient need not have ophthalmoplegia. If it is because of Sandow, patient can have sensory ataxia neuropathy with dysarthria and ophthalmoplegia that is not fitting in our case. The other Pol-G related spectrum being MNGIE like spectrum, where the patient will have predominantly gastrointestinal symptom associated with encephalopathy. To say it as a MSSC, patient does not have any faults. Our neuroimaging also, there was no correlate of PONS. So this is the scientific, so based on this scientific grounds, we have proceeded with genetic analysis in our patient. So initially we have proceeded with a routine score panel which screens for trinucleotide lipids, of which SCAR1, 2, 3, 6, 7, 10, 12 and DRPLA mutation was not detected. So we have, this prompted us to proceed with whole exome sequencing to find what is happening, of which protein kinase C gamma mutation, heterozygous mutation was turned out to be positive, which is consistent with the SCAR14. So what is this protein kinase C gamma? So in our case, I would like to highlight the genetic part which has happened. So in the coding region of 996, the cytosine has been replaced by guanine. It has also caused a mutation at the level of amino acid also. Threonine has been replaced by arginine, and this domain is located somewhere in the upstream of the C1 where I have quoted in the picture. So whenever there is a mutation of this coding region, it can alter the function of protein kinase C gamma. So what is this protein kinase C gamma is? Normally, if there is upregulation or some dysregulation of this protein kinase C gamma, the normal calcium homeostasis will get altered in the Purkinje cells. Ultimately, the Purkinje cell becomes dysfunctional. In protein kinase C gamma dysfunction, the Purkinje cell becomes dysfunctional. This Purkinje cell is widely distributed in the vermis. So in the vermis, the output from the vestigial nucleus will get dysregulated. So ultimately, this can explain why the autonomic dysfunction could be the manifestation of SCAR in patient with protein kinase C gamma. The another point to be noted here is, if there is a homozygous mutation, it is not compatible with life. Probably that could be the reason why there has been an earlier death in his siblings also. So our case is consistent with protein kinase C gamma, consistent with SCAR14. So we have tried to analyze the literature of SCAR14 various spectrum. Traditionally, SCAR14 has been told to have cerebellar ataxia plus or minus some axial myoclonus. But the clinical phenotype has been expanded recently in various case reports depending upon the genetic correlation. In one case report, it was just a pure cerebellar ataxia. In another case report, it was a progressive limb ataxia along with dysarthria with axial myoclonus. In another case, which they have reported in 2005, it was slowly progressive cerebellar ataxia. In another case, it was just a focal dystonia. In another case, cerebellar ataxia with some spasticity with reduced vibration. In another case, which they have reported in 2019 is cerebellar ataxia with deafness with some cognitive impairment. Another case which has been published recently in the Annals of Indian Academy in 2020, they have demonstrated sensory neuropathy of lower limbs with sensory ataxia. Probably this is the first case which demonstrates early autonomic neuropathy could also be an expanded phenotype in patients with SCA14. So our case highlights that there is a role of cerebellum in autonomic dysfunction. Suppose if there is a clinical situation where the patient is presenting to us with autonomic dysfunction with ataxia, if it is not fitting into the classical phenotype of MSA, the possibility of cerebellar ataxia should also be considered. So that is a thing that we wanted to highlight from our case. So our case turned out to be SCA14, sir, and patient has been treated with supportive measures, including vitamin B12, penicillin from a cardiology side since rheumatic heart disease has been found. And he also got folic acid, tamsulosin, as well as other fluid management has been done. Thank you, sir.
Any comments?
Once again, a nice presentation, a very
Sir,
nice,
Vijayan.
a very nice workup.
Yes,
Thank you.
Vijay.
Whenever these genetic abnormalities turn up, we are stumped. We
Illa,
learn
sir.
every time that we seem to get new genes abnormalities. So
Yes,
as
sir.
we have always been saying, whenever you do not know, we go for a genetic workup and try to find out.
Yes, sir.
Our working
Excellent.
diagnosis, sir,
Only
our
thing, sir.
working diagnosis was spinocerebellar ataxia only, sir. Only thing was the early autonomic involvement. So we investigated in that, and it turned out to be spinocerebellar.
Sir, Vijayan.
Please.
Excellent clinical presentation. Wonderful. The best I have seen till now.
Yes, Vijayan.
Thank
Very
you.
good. Yeah,
And,
being Coimbatore, you should be proud of it.
Sir, and long back before these genes came into play, Professor Rajaratnam from Madurai had described a group of ataxias called Query Madurai type. We had described long back, sir, when I was postgraduate, and he had presented it in the World Conference also. Where Niall Quinn also appreciated his paper, just similar type of ataxia, but
No,
they
but
had a lot of wasting, autonomic symptoms, ataxia, cerebellar features. I mean, all these cerebellar dysarthria.
No,
He
which scar?
described.
Which scar was it?
No, then we did not have any genetics, sir. This I'm talking about 30 years back.
No, but still clinically we would have classified, no? We would not
Clinically,
have
we
done the genetic
classified.
workup.
Those days, we called it the Madurai type.
No, from what you said, if Niall had appreciated, it should be SCA3. I don't know. But they should have
Must
had
be, sir,
Saccade.
but it was not exactly SCA3. It was something more than SCA3, so that
What about
Professor
saccadic
Raj,
movements in those cases?
the saccadic movements were affected, definitely were affected, sir.
That was something
Yes, sir.
significant. It was,
Yes,
if it
sir.
was there, yes.
Yes,
But
sir.
here the saccades are normal. And more and more of scars, we come to know the phenotypes only now.
Sir,
Most
in
of them
addition
had
to
predominant
minute,
autonomy.
should we regularly do a whole exome also, sir? Once they turn out to be negative, should we regularly do a whole exome for all patients suspected scars, sir?
If we need to establish the diagnosis.
Of course, yes.
Yes, sir.
Along with mitochondrial gene sequencing, of course.
Okay.
Okay, your case, you did the genetic study from your
Yes, sir.
funds, or did the patient have to provide the funds for that?
Sir, we have also provided funds, sir. From patient side also he contributed, but it via the scheme only, sir. Okay,
that's good. That is the advantage of institutional investigations. Yes, okay.
Anyway, it's an
Okay,
excellent case. Congrats, Sangavi, for a wonderful
Thank you, sir.
presentation. I think
Thank
we'll
you,
move
sir.
to the next case.
Okay, sir. Thank you.
Invite Dr. Anusha, an interesting case of anarthria.
They're not represented the same. Different. Yeah. It's here.
Anusha?
She's getting her slides ready.
Why she is the presenter is anarthric?
Anybody having experience with SCA 14 presentations earlier?
No, sir.
Not not read much also about SCA 14. I don't know how common it is in India. Sankavi or Shobana, have you looked at Indian literature? How common is SCA 14?
Sir, okay.
Go ahead, Sankavi.
Yes, sir. Actually, we have reviewed the annals of Indian Academy only, sir, which has actually they have published one case report 2 years back.
From where?
In which, sir, sir, actually from place I forgot, sir. Actually, it has been published in annals of Indian Academy only.
The autonomic symptoms are present.
No, sir. No, sir. This is the first case report where we have highlighted autonomic neuropathy, sir. In that case report, it was only a sensory neuropathy with ataxia.
Sensory small fiber?
It's a small fiber neuropathy along with cerebellar ataxia, sir, in that case. So in that case only, they have tried to compile all the clinical phenotypes that has been reported in SCA 14. In few cases only, they have reported some dystonia, myoclonus. In few other cases, it was only a pure cerebellar ataxia, sir.
You don't remember from where? You don't remember from where? Which institution?
Which institution? I'll just
actually. Okay, don't bother.
Okay,
we'll see.
Okay, sir. Actually, only one case got reported, sir, from India.
Okay.
Okay.
Very good. Anusha, can go ahead.
Anusha's slides visible?
Present with the chief complaints of inability to speak, difficulty in swallowing, and difficulty in closing the jaw since for 5 days. History of present illness, patient was apparently ordered 5 days back, and present complaint started as acute onset inability to speak in the form of complete loss of word output. However, he can able to comprehend the spoken or written words, and he can able to reply correctly with the gestures. History of difficulty in naming, repeating the sentences and words and reading was present because of there was no word output. History of difficulty in writing. At the same time, he noticed that there is difficulty in swallowing his saliva. There is history of difficulty in swallowing for both liquids and solids, and history of nasal regurgitation was also present. He also noticed that he felt difficulty in closing the jaw. After 2 days, however, attenders noticed that he can able to close the jaw while he was laughing or crying, or while he able to close partially while he was sleeping. And history of difficulty in protruding the tongue out was present, but he can able to protrude partially while he was coughing. And history of difficulty in marshalling the food present. No history of any new onset acute weakness of limbs, or no history of any sensory disturbances, no history of bowel or bladder disturbances, no history of any unsteadiness or vertigo, no history of any involuntary movements, no history of blurring of vision or defect in perceiving the colors, no history of decrease in sensation over the face, history of difficulty in chewing the food present, no history of deviation in angle of mouth or difficulty in closing eyelids tightly, no history of difficulty shrugging the shoulders or turning the head, history of emotional incontinence present. However, he used to cry immediately whenever the attendants come to visit him. And no history of memory disturbances or hallucinations or delusions, no history of slowness of activity or any recurrent falls. Coming to past history, is a known case of diabetes and hypertension since the last 10 years on irregular treatment. In 2018, he had a history of acute CVA, left hemiparesis. However, records were not available, but as per the patient words, they told like it's a query ICH. And after 1 month, after 10 days, he got discharged with MRS of 1/6. And again in 2020, he got another acute attack of CVA, which is of left hemiparesis. And that records are also not available. However, he discharged with MRS 1/6. And in 2022, again, he got an acute CVA, which now it is of right-sided hemiparesis. And again, he got discharged with MRS 1/6. But we don't know whether it's ICH or ischemic stroke, but records were not available about that. And the personal history, he takes mixed diet and is ex-smoker and alcoholic, no significant family history. So coming to summary, a 50-year-old male, known case of diabetes and hypertension with a recurrent CVA, he presented with acute onset anarthria, dysphagia, bilateral facial muscle weakness, tongue weakness, and emotional incontinence with no motor, sensory, cerebellar, or autonomic involvement. So structural localization is
Anushka, 1 minute. You said every admission he was discharged with MRS 1/6.
Yes, sir.
Does it mean that was it always 1/6, or did he improve in between and then whenever any event happened, then it went back to 1/6?
No, sir. First time he got weakness about of a 3/5 power, and he discharged with 1/6. Like weakness is improving, and again at the second attack he is having weakness again.
So every time he worsens. Every time he
Yes,
worsens. He improves and he worsens.
Yes, sir, worsens, and that is improving within 1 month. Maximum within 1 or 2 months he is getting improved.
Okay.
And symptom localization anarthria, it is due to some corticobulbar fibers from the precentral gyrus involvement, and inability to close the jaw. It is due to muscles of mastication, fifth cranial nerve involvement, and a dysphagia, it is due to 9 and 10 cranial nerves, and weakness of facial muscles is 7th cranial nerve. Unable to protect the tongue, it is tongue weakness, it is 12th cranial nerve, and emotional incontinence, corticobulbar fibers. However, we couldn't able to tell that whether it is supranuclear or infranuclear cranial nerve involvement, but based on other features like emotional incontinence, which is involving corticobulbar fibers, and anarthria, that is precentral gyrus, we can take that it is as supranuclear fiber involvement of all the cranial nerves. Based on this, we can think of pseudobulbar palsy, and also there is some automatic voluntary dissociation as per the history. They're telling like able to close the jaw in some instances. So we are thinking of some other rare variant of pseudobulbar palsy, Soperclass syndrome, with either vascular or demyelination cause, as it is an acute onset.
Will you consider apraxia here?
Sir, apraxia, they will try to speak, sir, but there will be the articulatory groping will be seen. The prosody will be lost. But here the patient even not even trying to speak, and he cannot even speak that like that articulation. Not at all.
Apraxia can result in anarthria also, isn't it?
Yes, sir.
So and you said at times involuntary movements he was able to do, voluntary movements only he was not able to do.
Yes, sir. Yes, sir.
So I was just wondering whether we would consider apraxia also as a manifestation here.
So we can think, but complete loss of word output is there, sir. But apraxia, at least some word output will be there, and there will be articulatory groping, like he couldn't articulate properly. So based on that, we thought of only anarthria.
Continue.
Okay. In examination, general examination, patient is conscious and oriented with vitals of blood pressure 130/80 millimeters of mercury, right arm supine position. Admission BP is 200/110 millimeters of mercury. Pulse rate is 78 per minute, normal volume, regular rhythm, no delays. No evidence of any pallor, icterus, cyanosis, clubbing or edema. No evidence of any neurocutaneous markers, and no skeletal abnormalities. His appearance is normal with normal behavior. Education stiff standard, right-handed person in MMSC of 19/30, out of which naming, reading, and repetition couldn't be examined as he cannot vocalize. And his conscious oriented to time and place, memory, immediate and recent remote memory were intact. He couldn't vocalize to the speech, and comprehension was normal. And reading, repetition, naming, unable to assess, writing and copying were normal. Lobar function examination couldn't find a significant deficit. He is approximately normals. On cranial nerve examination, first cranial nerve, he can able to perceive the smell, and visual acuity is 20/50 bilaterally. Visual fields were normal, color vision was normal. Fundus only grade 2 hypertensive retinopathy changes were present bilaterally. And the third, 3-4-6 cranial nerves, no ptosis, the pupils were normal in size, reacting to light, accommodation reflex was present, saccades and pursuits were normal. Fifth cranial nerve, facial sensation were normal, jaw jerk was exaggerated, and power of muscles of mastication couldn't be like weak. He couldn't even able to move. So weak of power muscles of mastication, and frontalis is normal, orbicularis oculi able to close tightly both eyes, and buccinator orbicularis ori platysma weak. He couldn't able to move. And eighth cranial nerve, Renistus air conduction more than bone conduction, Weber's node lateralization, Uvula, 9 and 10 uvula is midline. Gag reflex is present bilaterally. Palatal arch bilaterally symmetrical, but movements were absent. And the trapezius and sternocleidomastoid mastia were normal, and tongue is small, spastic, and unable to protrude the tongue or even move the tongue inside the mouth, and no fasciculations or atrophy. This is the patient. First photo is normally having difficulty in closing the jaw, and the second photo describes the patient while he was laughing involuntarily, he can able to close the jaw without knowing, and the third one, while he was sleeping, he can able to close the jaw partially. So video or quickly. He couldn't able to speak. Spinomotor examination, bulk, there was no significant difference bilaterally, it was normal. Tone was normal. However, power, there is 4+/5 power in all the limbs with the pyramidal pattern of distribution. And superficial reflexes, corneal reflex was present, conjunctival present, gag reflex present, abdominal is absent bilaterally, plantar extensor bilaterally. And deep tendon reflexes, biceps, triceps, supinator be exaggerated, ankle is 2+ bilaterally. And the glabella tap is non-accommodative, snout reflex present, deep facial present bilaterally, and palmamental absent. So sensory examination, touch, pain, temperature, proprioception, vibration, cortical sensation were normal. Cerebellatus, no nystagmus, no dysmetry normal. Extrapyramidal, no extrapyramidal signs were present. So coming to summary, it is about 54-year-old male, known case of diabetes and hypertension with a history of recurrent CVA, presented with acute onset neurological illness of anarthria, dysphagia, emotional incontinence, and bilateral facial muscle weakness and automatic voluntary dissociation with bilateral pyramidal pattern weakness and hyperreflexia, and no sensory, cerebellar, and autonomic involvement. So as the muscles of mastication are involved and jaw jerk was exaggerated, so we'd like to localize it to supranuclear fibers of the fifth nerve. Whereas buccinator orbicularis oris of the facial nerve were weak, however deep facial reflexes were present. So I would like to localize the supranuclear fibers of the seventh nerve. And the uvula is in midline, dysphagia is present, pharyngeal arch is symmetrical, gag reflex is present. So I would like to localize the supranuclear fibers of 10th, 9 and 10 cranial nerves. And he's unable to protrude the tongue, but small spastic tongue. So I would like to localize the supranuclear fibers of 12th cranial nerve. And brisk reflexes were present, bilateral plantar extensor and pyramidal pattern of weakness was there. So I would like to localize the bilateral corticospinal tract involvement. So based on all this, there is involvement of bilateral corticobulbar fibers, bilateral corticospinal fibers, and automatic voluntary dissociation as evidenced in pictures. So suggest of pseudobulbar palsy, rare variant of the Soberg-Class syndrome. Still we'll think of possibilities for vascular demyelination. We proceeded with investigations. Routine investigations were normal. CBC.
Just a minute. You are postulating only subcortical involvement.
Sorry, sir.
You are postulating only subcortical involvement.
Subcortical involvement, sir. More of cortical involvement, sir.
Where if it is cortical involvement, where do you postulate it? See, most of it you said upper motor neuron fibers of the various cranial nerves.
Yes, sir.
So where do you locate it?
Sir, corticobulbar fibers from the cortical area, so from the premotor cortex, we would like to localize, sir. Because as if it is in the subcortical region in the brainstem, subcortical region in basal ganglia thalamus, the fibers that are supplying the emotional part will also be involved. So there will not be any automatic voluntary dissociation will not be there. So as subcortical fibers are spared, there is automatic voluntary dissociation, sir. So I would like to localize to the cortical area, that is a premotor, precentral gyrus.
So if you are locating to the cortical area, as I was asking, would you consider it as apraxias?
Apraxias can also be considered, sir. Even buccofacial apraxia of the speech can also be considered. But
there were some findings suggestive of lower involvement, isn't it, in the brainstem also? Or no findings suggesting brainstem involvement?
No, actually, so some mixed findings were there, sir.
Exactly.
Reflex was not exaggerated, that is just present. And so we thought of only supranuclear fibers. Other features are suggesting of only supranuclear fibers.
You mentioned earlier, I think in the history, opercular involvement, do you still consider it to be a bilateral opercular? Because he has had bilateral strokes.
Yes, sir.
Could this
He's
be bilateral opercular involvement causing these features, particularly that of speech?
Yes, a bilateral opercular syndrome can be possible because he is having a recurrent CVA with bilateral involvement. 2 times left side and 1 time right side involvement is there. So based on this, we can think of bilateral opercular involvement only, sir.
Resulting in an artery as well.
Yes, sir.
Okay. Okay. If that, right, you proceed.
Yes. Other investigation, LFT or RFT was normal. Lipid profile, total cholesterol was 200, HDL 40, triglycerides 90, thyroid function test were normal, viral markers negative, PTA and coagulation profile normal, ANA profile was done which is negative, cardiac evaluation was done, 2D echo was normal, and CV doctor was also normal. So CT brain was done. It is showing some hyperdensity in the left frontal area, suggestive of intracerebral hemorrhage, and some gliotic changes with encephalomalacia in the right temporo-occipital lobe. Suggestive of old changes. So MRI brain was done. It is showing some subacute ICH, which is hyperintensive both T1 and T2, with the surrounding edema in the left frontoparietal area and some chronic infarct with diuresis in the right temporo-occipital region. However, SW is showing some hemosiderin deposits in the bilateral frontal lobe. So
this is the MRI and CT at present.
Yes, sir. At present, sir.
Okay.
In this admission, it is showing some bilateral frontal perisylvian involvement. So because of old and also the new one. So based on these features, we thought of bilateral opercular syndrome, which is vascular cause.
Amyloid angiopathy?
Sir, we thought of amyloid angiopathy based on the clinical things, sir. But to proceed further, we have to do the biopsy. As he's fitting as per the criteria, sir. But for the biopsy, we didn't proceed as per patient was not willing for the further investigation. We thought
continue, please. Sorry for the interruptions. You continue.
So, why it is interesting case of anarthria is there are many cases. First of all, opercular syndrome is a rare seen cortical type of pseudobulbar palsy. This is characterized by paralysis of facial, lingual, pharyngeal, masticatory, voluntary muscles with the preservation of automatic involuntary reflexive functions. So it is an area of the brain cortex covering the insula, inferior frontal gyrus, pre-posternal gyrus, angular gyrus, supramarginal gyrus, superior temporal gyrus. These are several connections between bilateral precentral gyrus and cranial nerves, and bilateral damage of this corticobulbar cause OPS. Why there is automatic voluntary dissociation is because the fibers carrying the automatic fibers will be going separately, whereas the voluntary fibers will be going separately. These emotional fibers will be going through the brainstem and then reaching the passing through the basal ganglia subcortical region and reaching the brainstem. However, these are spared when only the cortex is involved. That's why there is automatic voluntary dissociation. The types called bilateral and unilateral opercular syndromes. Bilateral are anterior or posterior. Unilateral also anterior and posterior. However, the hypothesis of only unilateral opercular syndrome is either because of a diaschisis. The involvement of one area that may cause distant cortical disconnection between to the other area that is causing the bilateral symptoms, even in the unilateral opercular syndrome. Sometimes we see like a CT MRI showing only unilateral cause, but when we do the PET or SPECT scan, there will be the lesion in the opposite side also. So this is a cause for the unilateral opercular syndromes. Why this is the interesting case of anarthria is there are a few case reports about opercular syndrome till now secondary to vascular cause. However, these vascular causes in all the case reports it is due to the ischemic cause. However, there is no till now only there are no case reports causing opercular syndrome secondary to the cerebral hemorrhage. So that's why we are presenting this case of opercular syndrome secondary to vascular cause, which is of intracerebral hemorrhage bilaterally.
He has also had ischemic lesions, isn't it?
Sir, ischemic lesions.
It's not always hemorrhagic. Both, mixture of both.
Deposits was seen in the bilateral frontal areas, and only chronic infarct with encephalomalacia was seen only in the temporo-occipital areas.
So he has had both.
Yes, he had
some hemorrhages, some ischemic involvement. And that is why amyloid angiopathy comes into as one of the leading causes.
First, it is amyloid angiopathy also.
Do you have an old CT scan of first, second episode?
Sir, old CT scans.
First, second episode.
So those were not available. So old reports were not available.
Continue with your presentation if you have something more.
Yes, yes. He was treated with anti-edema measures, antihypertensive, statins, and other supportive measures, and speech therapy. Percutaneous endoscopic gastrostomy tube was also inserted. And on follow-up, he could able to. He could able to close the jaw. However, there is no improvement in the speech. He couldn't even able to swallow or protrude the tongue. So we would like to present this case because say as a opercular syndrome causing secondary to hemorrhage is very less likely. So that's why we make it as an interesting case and we thought of presenting in this forum. Thank you.
Thank you. Thank you very much. Thank you. Alagasan, sir.
Yes, sir. It's a nice case. Thank you, Priyanka, for presenting this wonderful bilateral opercular syndrome due to probable myeloid angiopathy.
Okay. Thank you.
From any comments from the audience?
Sir Vijayan.
Yes, sir.
This also goes by a name, Mary Foix Chauhan.
Yeah, she already told that.
Yes, sir. Mary
She didn't
Foix.
mention it. Yes,
Okay.
of course.
Okay, thank you, sir. I didn't.
Chitrambalam, anything? It's your syndrome.
Yes, sir. We had in MAN, sir.
Yeah, I know you've done it. Yes, that's why I'm asking you.
Yes, sir. But here the cause of bleed, sir.
No, amyloid angiopathy enna portha mattum.
It's over hemorrhage.
In SWA, were there any asymptomatic microhemorrhages significant in number and location?
Hemocydrosis la irundhirukuma.
Only
Yes, sir.
hemocydrosis deposits, some micro.
They are showing only one cut of SWA, sir.
Yes, sir.
Were there any other asymptomatic microhemorrhages? These are all
No,
bleeds, sir. Did they have any asymptomatic?
No, sir. No, sir. No other asymptomatic bleeds were present, sir.
So in a bilateral cortical opercular syndrome,
Yes.
my basic doubt is whether it is a true anarthria or it is a mute. Lack of speech initiation.
Sir,
Difficult areas. Go ahead.
It's a significant apraxia of speech. The
That's
speech
what I
apraxia
thought.
of significant. Yes, sir.
Anushka, go ahead. You are presenting. He has asked a question.
Sir, yes, sir. There is no initiation. So initiation is not there. He's not even trying to speak. He was trying to speak, but there's no initiation. He couldn't able to articulate. He couldn't able to move the tongue also. As bulbar fibers that are supplying the speech, tongue muscles are involved. He couldn't able to move the tongue. So it is a complete thought of a complete anarthria.
Yeah,
What
the question.
Sir
If
is
you say
telling
lack
is
of
anarthria
initiation,
is
then
yes,
it's a mute, isn't it? The
Yes.
word anarthria meant for only the paralysis of the orofacial and tongue muscles, probably due to bulbar or pseudobulbar palsy.
Yes, sir.
During recovery, was he able to make any sounds, utter any words?
No, sir. No, sir. He didn't improve. Speech was not improved, sir. Not even making a sounds, but he could able to close the jaw. Only that part has improved. Not
What
even,
about the past history before this episode?
before this episode? He was working. He could able to work, and his speech was
No,
also.
was he able to speak at that time?
Yes, sir. His speech was also completely normal.
Oh.
Yes, sir. Acute onset
he has
of-
an ischemic lesion, right PCA infarct. Are we going to give antiplatelets for the secondary prophylaxis of this right PCA infarct?
Yes, sir. We have to start antiplatelets after 2 or 3 months, sir. But it was only 1 month.
Chitrama, sir, we do not know it is an infarct. Maybe a eclampsia is caused by the hemorrhage also. We didn't have any previous scans.
But the way it looks, sir, just covering the PCA territory of right
Distribution,
medial
yeah,
temporal
distribution
and-
of the lesion, yes.
Yes, sir.
And generally, Chitramalam,
Yes, sir.
in amyloid angiopathies, antiplatelet agents does not help. If I subject to correction.
Yes, sir. It may worsen. It may
Yes, sir.
precipitate hemorrhage. So, okay, we'll move on to the third case
Thank you, sir.
from Priyanka. the case of polyradicular neuropathy.
Again, a nice case, well worked up and presented. Thank you.
Good morning, sirs and ma'am. My topic for today is a rare presentation of polyradiculoneuropathy. So, a 59-year-old male presented with chief complaints of weakness of bilateral lower limbs since 6 months, weakness of bilateral upper limbs since 5 months, and slurring of speech since 3 months. So, history of present illness. Patient was apparently normal 6 months back, followed by insidious onset, gradually progressive weakness of bilateral lower limbs in the form of difficulty in rising from squatting and sitting position, followed by difficulty in gripping chappals, associated with slippage of chappals with knowledge. It started simultaneously in both the legs. 1 month later, he developed weakness of bilateral upper limbs in the form of difficulty in raising hands above the shoulders. And 3 months after the initial insult, he also developed difficulty in gripping objects with a hand. It is associated with a feeling of flailness of limbs, not associated with any tightness or involuntary twitching of limbs. 3 months later, he also developed slurring of speech in the form of breathy nasal quality of voice. He is able to understand what is told to him and he is also able to answer correctly. But there is slurring in the form of nasal quality of speech. It is associated with difficulty in swallowing for both solids and liquids. Also associated with nasal regurgitation of fluids and drooling of saliva. History of difficulty in marshalling food in the mouth is present. No history of numbness or tingling or paresthesias or dysesthesias in any of the forelimbs. Able to feel sensation of clothes and able to feel the mosquito bites. History of cotton wool sensation is present. History of tremulousness of hands while reaching out for objects is present since the last 5 months. It is associated with spillage of food while eating. No history of any unsteadiness of gait while walking and no history of any bowel or bladder involvement. No complaint of any abnormal smell sensation. No complaint of any blurring of vision or double vision or restricted eye movements. Complaint of drooping of right eyelid is present since the last 12 years. No complaint of any abnormal sensation over the face. No complaint of any difficulty in tight closure of eyelids or deviation of the angle of mouth. No complaint of any decreased hearing or tinnitus and no difficulty in lifting shoulders or turning head from side to side. No history of any memory disturbances, no history of delusions or illusions or hallucinations, no history of sleep disturbances, no history of any emotional incontinence or lability, and no history of any fever or loose stools or loss of weight or loss of appetite. Past history, he has a history of road traffic accident was present 12 years back with traumatic SDH. At that time, he developed right-sided traumatic third cranial nerve palsy and is not a known case of hypertension or diabetes or CVA or CAD or any epilepsy. Personal history, patient takes mixed diet and is a chronic smoker and alcoholic. So summary, a 59-year-old male presented with insidious onset, gradually progressive flaccid quadriparesis, bilaterally symmetrical, proximal and distal since the 6 months, associated with sensory and bulbar involvement in the form of dysphagia and dysarthria with no higher mental function or autonomic involvement. So structures involved. First, the patient has weakness, which is ascending, bilaterally symmetrical, proximal more than distal, with flailness. So it is a pure motor element weakness, and I would like to consider it to motor radical. Then the patient has a cotton wool sensation, but tremulousness of hands is present. This tremulousness, according to history, I would like to localize it to either sensory radical or large fiber peripheral now. The patient has dysphagia, dysarthria associated with nasal regurgitation of fluids. So I would like to consider it to 9 and 10 cranial nerves. And the patient has a history of difficulty in marshalling food in the mouth is present. So 12th cranial nerve. And the patient had an right eye ptosis present. That was an old insult. So it is a post-traumatic third cranial nerve palsy due to some old insult. So the structures are motor radicals, large fiber peripheral nerve, and the lower cranial nerves are involved. That is 9, 10, and 12 cranial nerves are involved. So diagnosis, I would like to consider it as a variant of CIDP. And in the etiology, first etiology I would like to consider is inflammatory. In the inflammatory, I would like to think of either autoimmune or secondary to some connective tissue disorders. Because the lower cranial nerves are involved, I would like to consider sarcoidosis. And the second differential, because it is rapidly progressive and severe at the onset, I would also like to keep paraneoplastic as a differential.
Why do you say it's variant of CIDP?
Because the lower cranial nerves are involved, sir. Usually in typical CIDP, cranial nerve involvement is very less. It is seen only in 10 to 15% of cases. And also patient has a tremulousness of hands and cotton wool sensation, ataxia is present, and also severe weakness which started progressed very rapidly within the 6 months. These are all atypical findings in a normal CIDP cases. So I would like to think any variant of CIDP.
CIDP is a wide spectrum. CIDP is a wide spectrum. Okay.
Before that, what did they do for the subdural hematoma?
Sir, it was 12 years back, sir. Those reports were not available. He was treated.
No, at that time he developed the left third nerve palsy.
Right third.
How did it recover, and what did they do for that?
So those reports were not available, sir. It was 12 years back.
But was he operated? You must, that should be there, no? He should be able to say he was operated.
No, sir, he was not operated.
Was it a small hemorrhage, or they have just left it alone?
They left
or
it.
The third nerve palsy was persistent for a long time?
Yes, sir. The third nerve palsy was persistent, sir. From the 12 years, it was persistent till now, but they did not operate on him, sir. He was started on anti-epileptics at that point of time and anti-edema measures, but they discontinued all those drugs after some 2 to 3 months, sir.
So what about the symptomatology? What did he have? Headache, vomiting?
Yes, sir. After that road traffic accident, he had a loss of consciousness is present, sir. That lasted for around 2 hours only. And no history of any seizures at that time. Then he was taken to the hospital and some scans were done. He regained consciousness after 2 hours. And he had amnesia for that 2 hours. He did not remember anything. After that, he developed this third cranial nerve palsy and he was treated symptomatically.
But they would not have left him alone, no? Just he had loss of consciousness, he had third nerve palsy, he had features of ICT. They would not have left it alone, no? What did they do for that? What was any hint for that treatment for that partner?
So they told they have given injections, sir. All the injections were given. Other than that, he was not operated regarding that, sir.
He was taken to which hospital?
So some 12 years back, it was some local hospital within the same village, sir.
12 years back, we were doing DMO.
Yes, sir. It was.
Yeah. What is it they would have done? They would have done something, no? That was not a dark age. Anyhow, that was a sort of illuminating age.
Yes.
At that age, at that time, neurosurgery has developed.
Yes, sir.
Nothing has been done.
He was not operated, sir.
Okay. Leave it alone. Yeah.
Priyanka, it's only 6 months duration.
Yes,
Pure
sir.
motor with the bulbar.
Yes, sir.
Wouldn't we think of some other treatable secondary causes, motor neuron disease, or pure motor neuropathies, like any exposure to any heavy metals?
No, sir. But patient also had the sensory symptoms like cotton wool sensation is present, sir. With tremulousness of hands is also present. So pure motor neuron disease.
Okay.
No history of any exposure to any toxic metals is not present, sir.
Priyanka, the tremulousness, you need not consider it seriously because it's part of the neuropathy.
Okay. Sir.
Neuropathy can produce tremulousness. All of us do know. The question was any toxic or metabolic. What was it? What was the question? Was it toxic?
No, sir. He did not have any toxic exposure, sir.
Fine. Yeah, you can continue.
What was Ascent like? He developed a weakness of both hips, followed by respiratory weakness, bulbar weakness.
Yes, sir.
Within a span of
6 months, sir.
It was going on slowly for 6 months.
Yes, sir. Yes, sir. Yes. 6 months, lower limbs first, upper limbs next, bulbar muscles after that. So yes, gradually progressing. So over a period of 6 months.
Yes, sir.
What did they do for that? Once he started developing weakness of the lower limbs, did he go to any hospital?
Sir,
So
actually,
any treatment was started at that time?
yes, sir. 2 months after the weakness of bilateral lower limb started, he went to another hospital, sir. There, he also had at that when he developed weakness of the bilateral upper limbs, he went to the hospital. Then they have evaluated him, sir. He also had at that time difficulty in breathing because he also had that bulbar symptoms. He had difficulty in breathing. So have evaluated everything, sir. Outside they have done. Sorry, sir. Outside they have.
No, difficulty in breathing does not mean that he has got weakness of the bulbar weakness.
Yes.
It must be intercostal weakness also,
Okay,
or
sir.
diaphragmatic weakness. What is it he developed? What treatment was given? What investigation was done at that time? 2 months back.
Okay, sir.
Why I am asking is it AIDP which is just going on?
Yes, sir. 2 months back, so nerve conduction studies were done, sir. In the nerve conduction studies, they were showing axonal neuropathy, sir. Bilateral lower limbs and upper limbs, axonal neuropathy is present. And also CSF is done, sir. CSF protein is elevated. It was 105 at that point of time. And also they have done MRI brain and MRI spine, sir. MRI brain is normal and MRI spine is also normal, sir. And following that, because he had some breathing difficulty and all, they have done that CT chest and also PET scan is also done, sir. In the PET scan, they had multiple hilar lymph nodes are present, sir. Hilar and para-aortic periesophageal lymph nodes are present. Other than that, it is not significant. In the CT chest, it was showing ground glass consolidation in the bilateral lower limbs.
No, PET scan report will not show the presence of the nodes. What about the metabolic hypometabolism?
Yes, sir. Metabolically active lymph nodes are present in the paratracheal, periesophageal, and hilar lymph nodes.
Meghandan sir, she is not presented completely. She is only at the history stage. She has to present the findings and then go with the investigations, whatever has been done in the past and what she has done now.
Okay, okay, sir.
Good. Priyanka, go ahead with the examination.
Okay, sir. Okay, thank you. So on examination, patient is conscious and oriented. Vitals BP is 120 by 80 millimeters of mercury in the right arm supine position. Pulse rate is 86 per minute and no radioradial or radiofemoral delay. No evidence of pallor or icterus or cyanosis or clubbing or pedal edema. No evidence of any neurocutaneous markers and no skeletal deformity. Higher mental functions, patient is oriented to time, place, and person. Memory is immediate. Recent and remote memory is intact and comprehension is normal. Reading, repetition, and naming is intact. Writing and copying couldn't be assessed because the patient has weakness and the lobar functions are normal. Patient's speech has flaccid dysarthria. Cranial now examination. Cranial now he's able to perceive the smell. Second cranial now, visual acuity is 20 by 30 bilaterally. Visual fields are normal. Color vision is normal. Fundus is also normal. And the 3, 4, 6 cranial now, patient has a ptosis on the right side. In the extraocular movements, elevation and depression are restricted on the right side. Pupil size is also 2.5 millimeters. It is sluggish reacting to light, whereas on the left side, it is normal. Indirect light reflex is normal and accommodation is also normal. In the fifth cranial now, sensation over the face is normal bilaterally. Muscles of mastication are normal and jaw jerk is also normal. Coming to seventh cranial now, frontalis is weak bilaterally. Orbicularis oculi is weak bilaterally. He is able to close the eyes, but not tightly. Buccinator is weak bilaterally. He is not able to blow the cheeks. Orbicularis oris and platysma are also weak bilaterally. In the eighth cranial now, Rinne's test, air conduction is more than bone conduction, and Weber's test, there is no lateralization. 9, 10 cranial nerves, uvula is in the midline. Palatal arches are also bilaterally symmetrical, but gag reflex is diminished bilaterally. The movement is reduced bilaterally and sensation is also decreased. 11th cranial now, trapezius and sternomastoid are normal bilaterally. The 12th cranial now, on protrusion of the tongue is deviated to the left. However, it is not associated with any wasting of fasciculations. Coming to the spinomotor examination, the bulk of the patient is normal. Arm is 26 centimeters and the forearm is 22 centimeters bilaterally. Thigh it is 34 centimeters and calf it is 28 centimeters bilaterally. But wasting of the thenar muscles of the bilateral hands, right more than left, it is seen. No fasciculations are noted and tone is reduced in all the 4 limbs. Coming to the power, shoulder, it is at the shoulder joint, it is 2 by 5 bilaterally, and the elbow joint, it is right side 2 by 5 and the left side it is 3 by 5. Whereas in the wrist, it is 2 by 5 on the right and 3 by 5 on the left. Hand grip is weak bilaterally. In the hip joint also, right side it is 2 by 5 and the left it is 3 by 5. In the knee joint, it is 3 by 5 bilaterally, and in the ankle also it is 3 by 5 bilaterally. EHL is weak bilaterally. Coming to the superficial reflexes, corneal and conjunctival are normal bilaterally. The pharyngeal gag reflex is diminished bilaterally. Abdominal reflex is absent, whereas the plantar is flexor bilaterally. Coming to the deep tendon reflexes, biceps, triceps, supinator, knee, and ankle all are absent bilaterally. Sensory examination, touch, pain, temperature is normal, and joint position sense and vibration, it is impaired in the bilateral lower limbs till the knee joint and the bilateral upper limbs till the elbow joint, but the spinal vibration is normal. Cortical sensations, that is tactile localization, 2-point discrimination, graphesthesia, and stereognosis, they can't be assessed as the primary sensation itself is impaired. Cerebellar, there is no nystagmus, but finger nose test and finger nose test is impaired bilaterally. Dysdiadochokinesia is present, and gait and tandem gait, it couldn't be assessed due to weakness. Extrapyramidal symptoms, patient does not have any rest tremor or rigidity or bradykinesia. In this, these are the photographs. This is the first photograph. We can see the frontalis overactivity on the right side of the patient due to the right eye ptosis. In the second photograph, the tongue on protrusion, the tongue is deviated to the left side. The third photograph, we can see the bilateral thenar muscles wasting. And in this first video, this is the finger nose and finger nose test. On the right side, we couldn't do properly because it had a severe wasting. On reaching the target, the tremor is more.
அப்புறம் உங்களோட மூக்கு நுனி தொடுங்க. விரல தொட்டிட்டு கரெக்டா விரல தொட்டிட்டு மூக்கு நுனி தொடுங்க. என்னோட விரல தொட்டிட்டு மூக்கு நுனி தொடுங்க. நீட்டுங்க. விரல தொடுங்க. நீட்டுங்க. விரல.
Reaching the target, yes, the tremulousness increases.
வேகமா பண்ணும்.
Priyanka, is this after treatment or before treatment?
So this is after steroids, sir. After IV steroids.
Before that, you were not able to assess. Before that, were you able to assess the coordination?
In coordination, sir, before that also it was similar, sir, actually. But before that, actually, while he came, he had a severe aspiration pneumonia. He developed aspiration pneumonia, sir. At that time, he was diagnosed with CIDP and we have started on steroids. Then that aspiration and all improved. After that only, he was able to sit. At that point of time only, we have noticed this, sir.
No, I wanted to know the upper limb weakness at that point of time and now. That is why I was asking this question.
Yes, sir. Yes, sir.
Was he more weak at that time that you could not perform the coordination test?
Yes, sir. Actually, he was weak, sir, because he also had aspiration and the weakness was also much weaker, sir.
Okay.
At that time, we couldn't do the coordination test, sir.
Correct. Continue.
Yes, sir.
So you don't need necessarily to bring. Okay, we can. I don't want to preclude your discussion. Go ahead.
Okay, sir. So this is the second video. The patient protruding the hands with eyes open initially.
கண்ணு மூடிக்கோங்க.
And on closure of the eyes, the pseudo-atherosclerotic movement is increasing. And this is the speech of the patient.
Appa, Tata, Kaka, Chakravarti Rajagopal Achari. Chakravarti Rajagopal Acharya. Amma Abba. Lalli Lilli. Gangai Mangai.
And these are his own words. He is trying to tell his address.
ವರ್ಷಗಳಿಗೆ பள்ளி தாலுக்கா ஈரோடு மாவட்டம் 63 83 14 பின்கோட்
Says flaccid and bulbar dysarthria.
ஈசி செல்வன்
So summary, it is a 59-year-old male who presented with insidious onset, gradually progressive quadriparesis, which is bilaterally symmetrical, proximal more than distal, with wasting, with sensory disturbance in the form of impaired vibration and joint position sense, with some intentional tremor in incoordination, with bulbar involvement in the form of dysarthria and dysphagia, with no higher mental function or bowel and bladder involvement. So the structure localization, the weakness, it is a ascending type associated with areflexia and also wasting of the thenar muscles of the bilateral hands it is present, proximal more than distal. So pure motor element weakness, I would like to think of motor radical. Then impaired vibration and joint position sense in the bilateral, impaired vibration and joint position sense in the bilateral lower limbs till the knee joint and bilateral upper limbs till the elbow joint, large fiber peripheral nerve, and intentional tremor with incoordination. I would like to think of cerebellar hemisphere, sir. Difficulty in tight closure of the eyelids and unable to blow the cheeks, bilateral 7th cranial nerve palsy, dysarthria and dysphagia with diminished gag reflex, 9-10 cranial nerves, and on deviation of the tongue on protrusion, deviation of the tongue to the left side on protrusion, I would like to think of 12th cranial nerve palsy, and right eye ptosis with elevation, depression, restriction, that is a right-sided 3rd cranial nerve palsy, that is an old insert. So the structures I would like to consider are motor radicals, large fiber peripheral nerve, and also cerebellum, and 7, 9, 10, 12 cranial nerves. So suggestive of any variant of CIDP. In the variants etiology, I would like to first think of any autoimmune. In that autoimmune, I would like to think of any nodoparanodopathies. And the second, again, I would like to think of paraneoplastic CIDP. Proceeding
At this point, I am not, I wouldn't
Why should
agree
you call
with-
it a variant, sir? Why should the word variant be used?
That's what I asked her initially itself.
Yes,
Now,
yes, sir, yes.
before that, I would not agree to cerebellar involvement. Any weak limb which is improving will show some amount of incoordination, which I would not per se think it is cerebellar involvement. See, once you consider it as a cerebellar involvement, you are bringing another component, another anatomical involvement apart from the neuropathy. You are bringing in neuropathy plus cerebellum. I would continue to keep it as only neuropathy rather than cerebellar involvement. And I would think that you showed some incoordination. I would think that is due to the neuropathy per se and not due to cerebellar involvement. So also the dysarthria showed is probably resultant of the nerves involvement rather than cerebellar. So I would discount the cerebellum, and then other things are there. So to me, as I said, CIDP is a wide spectrum. Of course, you are at liberty to consider it a variant, but that is what Chitrambalam is also asking. Why do you consider it as a variant?
And second, what are the clinical picture? What are the clinical features to make you think about a nodopathy or a paranodopathy? Is there anything specific that makes you think about a paranodopathy or nodopathy?
Yes, sir, because certain features are atypical, sir, especially the lower cranial nerve involvement. It is usually seen in only less number of CIDP cases, whereas in nodoparanodopathy, it can be seen. And also that tremor can be seen in, as I said, that variants of CIDP, nodoparanodopathy, there can be a prominent sensory ataxia as well as tremor, as well as lower cranial nerve involvement. All these features can be seen in autoimmune nodoparanodopathies, sir. And also after this, actually the patient, we have given IVIG, sir. The response to corticosteroids and IVIG is also very less, sir. Whereas after giving rituximab, the patient is showing improvement, and that point also favors a nodoparanodopathy.
1 minute. You said initially he was weak and then improved. I thought that you said because after steroid treatment he improved. Isn't it so?
Yes, sir. Initially had that aspiration pneumonia and all, sir. He showed minimal improvement, sir, but not.
Yeah, we didn't go into the treatment schedule, how you did and how you progressed to treat him. So maybe as you go on to mention about the treatment, let's see and analyze at that point.
Okay, sir.
You go ahead with the, okay, this is what you thought, and go ahead with the investigations and then the treatment.
And coming to the investigations, the CBC, LFT, RFT are within normal limits. ESR is raised 92 and CRP is positive. Serum total CPK is 20, normal. Serum ACE levels is 42, normal. And serum calcium is 8.8. ANA profile is positive. However, the ANA antibodies were turned out to be negative. And C-ANCA, P-ANCA were also negative. Serum protein electrophoresis showed an only normal pattern. And urine Bence-Jones proteins were also normal. Thyroid profile is normal. And viral markers like HIV, HBsAg, and HCV were non-reactive. Sputum CB-NAT was negative. CSF cytology is acellular, whereas CSF protein, it was raised 105, and glucose 77, and LDH, it was 231.
Is this at present CSF analysis or the CSF analysis done 2 months ago?
That 2 months ago, that CSF protein was 136, sir, at that point of time. Now it was 105, sir.
Okay, continue. Allegation, she can continue, no?
Yeah, yes, sir. Yes, sir.
The nerve conduction study shows severe bilateral upper limbs and lower limbs axonal neuropathy, sir. The left median bilateral ulnar and bilateral peroneal are not stimulatable, and the lower limbs also sural is not stimulatable, and upper limb sensory are also not stimulatable. So bilateral upper limbs and lower limbs severe motor and sensory axonal neuropathy. This is the EMG of the patient, sir.
Can you show the nerve conduction study again, please?
Yes.
Just show that. Okay, fine. And lower limbs, right. Left tibial, okay. Okay, continue. Thank you.
Yes.
F waves?
Yes. F waves were absent, sir.
Only the tibial was there.
Present,
Tibial was there and tibial was prolonged.
Yes, sir. Left tibial, it was prolonged, sir. Yes.
Okay.
So this is the EMG, sir. This is the spontaneous activity. Spontaneous activity is present. And this is the Q.
That's okay, you can continue.
Yes. And this is the Q map, sir. Sorry. Interferencer, which is showing incomplete interference. And the nerve biopsy. This is the nerve biopsy report. Nerve biopsy is reported as chronic axonal neuropathy. And this is the MRI brain. The patient MRI brain is normal. And MRI spine is done. It is also normal. And the CT chest, these are CT chest plain and contrast. And the CT chest shows ground glass opacities in the both lung fields, patchy consolidation in the both lung fields, and collapse consolidation in the left lower lobe. Bilateral pleural effusion is present. CACT, this CT chest was done previously before coming to our hospital. After coming to our hospital, we have done CECT chest. It shows soft tissue dense enhancing lesion in the left upper lobe, possible malignant lesion. And this is the PET CT that was also done previously. And the PET CT showed diffuse ground glass haziness in the bilateral lung fields and metabolically active prominent right upper paratracheal, bilateral lower paratracheal, paraesophageal, and bilateral hilar lymph nodes. And because there was a lesion in the left upper lobe, we tried to do an ultrasound guided biopsy from the left upper lobe lesion, but the sample was inadequate. The report was not correctly obtained. So oncology opinion is obtained regarding that left upper lobe lesion. They have opened as atypical CIDP query carcinoma lung. They have advised a rebiopsy from the lesion, and the patient can be started on injection rituximab. So on treatment, patient is initially treated with IV steroids, IVIG, and other supportive management. Patient showed mild response to IVIG. Then injection rituximab was given. Patient is showing improvement after rituximab injection.
Now, how many days you gave IV steroids? How many days you gave IVIG? And when did he start improvement?
Sir,
you
IV
have to mention.
Yes,
Yeah.
sorry. IV steroids, sir, we have given 5 days, sir, IV steroids. Followed by that, we have tapered it, sir, to oral steroids. Then
when did you give IVIG?
IVIG, we have waited for 2 weeks. 2 weeks later, we have given IVIG, sir.
2 weeks, there was no improvement.
There is only minimal improvement is present, sir.
Minimal improvement in the sense power did improve.
Power in the sense initially is not able to move his hands, sir, like only 1/5, 2/5 power he could do, sir, after IV steroids.
After IVIG?
IVIG also there is actually no improvement, sir. After IVIG also same, sir, 2/5 power only he remained.
And after Rituxi?
Rituximab, now he is able to raise his hands above the shoulder, sir. 3 to 4 minus, yes. So this is an article, the clinical relevance of distinguishing this autoimmune nodopathies from CIDP, longitudinal assessment in a large cohort. In the recently updated European Academy of Neurology Peripheral PNS guidelines on diagnosis and treatment of CIDP, disorders associated with paranodal antibodies are no longer classified as CIDP, but they're grouped under the term autoimmune nodopathies. The patients with autoimmune nodopathies, they have specific clinical features and a poor response to first-line treatments with IVIG, but may improve after plasma exchange or rituximab. And this is another article where it shows neurofascin IgG4 antibodies in
One minute. You mentioned about they have some specific features. What are the specific features?
Sir, I have kept in the next slides.
Okay.
Yes. So neurofascin IgG4 antibodies in CIDP are associated with disabling tremor, the disabling tremor and poor response to IVIG. These are NF155 antibodies. So these are in that study, these are the 4 patients who had that disabling intentional tremor along with that CIDP picture, and none of these 4 patients responded to IVIG, but they have responded to, some of them responded to plasma exchange and some of them have responded to rituximab. So NF155 is the glial ligand of the contactin 1 Caspr-1 complex at the paranode region, and it has a role in myelination and node of Ranvier functional organization. Selective knockout of this NF155 isoform causes a severe demyelinating neuropathy with a dramatic reduction in the conduction velocity and also degenerative changes in the Purkinje neurons, therefore leading to prominent tremor and ataxia. And features of the tremor suggested a cerebellar origin, although other signs of cerebellar impairment like nystagmus and oculomotor disturbances were not present. So this is another study, anti-neurofascin antibody in patients with combined central and peripheral demyelination. So other than ADAM, in patients who are having combined central and peripheral demyelination, we can also think of NF155 antibodies. In this study, as one of the target antigens for this combined central and peripheral demyelination, they have identified neurofascin, this NF155 antibody, and the patient has clinical features of both peripheral nervous system involvement and also central nervous involvement. But central nervous system involvement usually, in these cases, what they have observed it is mostly typical for MS, that is they have spinal cord lesions and all. But in some cases, they have also observed that bulbar involvement can also be present and cerebellar involvement have also been noted. So these are the typical clinical features when to suspect a nodoparanodopathy. Clinically, patient will have acute to subacute onset, predominantly distal motor neuropathy with rapid progression. Our patient had rapid progression, severe nadir disability and associated features in the form of severe sensory ataxia. Our patient had sensory ataxia and tremor. Our patient had tremor, neuropathic pain and cranial...
One minute. You say your patient has sensory ataxia. And why do you say cerebral ataxia also? You say, why do you say he had sensory ataxia?
So that pseudoathetosis moments are present, sir.
Then why did you go on for cerebellar involvement?
Cerebellum, because the incoordination is also present.
As I said, it can be present in weakness, improving weakness. And in addition, you already said that there is a sensory involvement. So this is a neuropathic tremor to me, not necessarily a cerebellar involvement. But anyway, if you think it's cerebellar, fine, that's fine. You can continue.
Okay. Cranial neuropathies are cranial neuropathies, and our patient also had cranial neuropathy involvement. And
do you understand? Do you take up what Professor VN says?
Yes, sir. Because sensory.
Why do you bring cerebellum into this picture at all?
Yes, sir.
Why do you want to commit yourself as cerebellar involvement?
So because the incoordination is
it's pure neuropathy.
Yes, sir.
CIDP, paraneoplastic. And when you want to bring cerebellum, cerebellar involvement, cerebellitis, or subacute cerebellar degeneration, all those pictures into this field?
Because she wants to make it peripheral and central involvement. That is the reason why she has brought in.
The lower
cerebellum.
cranial nerves are also involved. So lower cranial
Lower
nerves.
cranial nerves does not mean it is a central involvement. Sorry,
Sir,
madam.
clinically, we thought more in terms of only large fiber neuropathy, sir. We also had the same doubt. We're
Yes.
more in favor of a large fiber neuropathy with a neuropathic tremor only.
Yes.
And also more significantly, there was no demyelination. You consistently said it was an axonal neuropathy.
Yes.
And at the paranodal, you said it's a predominant demyelinative neuropathy. That is also not fitting in. If you say it's an atypical variant, that is also an atypical presentation. Am I right? You
Yes.
said
but,
it's a
but
predominantly
the nodal,
demyelinating, no?
so nodal or paranodal involvement usually leads to loss of SNAP or CMAP, sir. So in that, whenever we have a loss of CMAP or CMAP or SNAP, we used to call it axonal, but it is not so. When it is a nodal or paranodal involvement, the nerves are inexcitable. So our old way of reporting nerve conduction as demyelinating axonal has to be revised. So these can be nodopathies. That's what we used to say, sir. What we are reporting only as axonal because there is no SNAP or CMAP, they can be nodal or paranodal, sir. Paranodal nodal involvement leads to loss of excitability, sir. So,
That's
so
true.
we can't call it axonal, sir. It's only inexcitable nerves and very low amplitude. This may be an axonal neuropathy, or it can be a nodopathy or a paranodopathy.
That is why we go in for proximal stimulation and see whether there is any evidence of demyelination. Here, the only thing was one nerve showed a prolongation of the F latencies.
Yes.
But at other times, there was nothing to suggest it. And her amplitudes were low. She also, of course, her
Not stimulated.
EMG is not going to say whether it's axonal or demyelinating. But you found a lot of changes, isn't it, in EMG? Spontaneous activity.
Spontaneous activity is present, sir. That also because more spontaneous activity usually indicates because if there is severe axonal loss only.
Correct. That's why I wanted to know.
Not necessarily,
EMG was
sir.
suggesting.
That's what. So it is not necessarily axonal. It can neuropathy is so severe that it leads to all axonal changes in NCS and EMG also.
Yes.
Yeah.
Only serial nerve conductions would have solved the issue. Initially, if you had done a nerve conduction where there were elicitable conduction, this thing, and then it has led to loss of CMAP or SNAP, then we can say it has evolved like this. Otherwise, to call whether it is axonal or demyelinating at this point is difficult, sir. Even nodopathy can cause similar changes of inexcitability.
Priyanka, when she was evaluated 2 months ago, did they
Yes.
have a nerve conduction done at that time?
Sir, at that point of time also the nerves were not stimulatable. Sir.
Okay.
Only 2 nerves were stimulatable. They also have only axonal changes are present.
Okay. At this time, did you look for Neurofacin 155 antibody?
Sir, actually we are planning to send, sir. It is regarding the affordability issues.
No, you'll have to send it to Amrita.
Okay,
They
sir.
are doing it there.
Okay, sir. Okay, sir. We are
Okay.
planning to send.
Amrita directly is a little cheaper than through the
An agent.
MOU lab, sir. Yes, sir.
Okay, sir. Okay, sir.
From an institution, you can directly send to Amrita. And you can also say the patient is not affordable. They will show concession also.
Okay, sir. Okay, sir.
Now continue with your presentation, whatever you have to say further.
Yes, sir. Sir, in the electrophysiology for nodoparanodopathy, there will be reversible conduction failure and reduced motor conduction velocity will be present, sir. Marked prolongation of distal motor latencies and F-wave latencies, but there can be conduction block and there can be also decreased CMAP amplitudes. And also because that decreased CMAP amplitudes are non-stimulatabilities because of the early axonal loss. So the decreased amplitudes are non-stimulatabilities due to early axonal loss, which is seen in a nodoparanodopathy. And
The answer to Chitrambalam's question, when the nerves are inexcitable, most often they are considered to be axonopathies rather than demyelinative neuropathies. I said considered. It's not that it cannot happen, but it's rare to happen in demyelinative unless the distal segment itself shows demyelination. It's unusual. So most often it is considered an axonal.
Yes, sir. But in nodopathies, it happens rapidly, sir. So very rapidly, the axonal changes are seen in a nerve conduction, sir. If you follow so that's why even the previous conduction showed a loss of CMAP. Sir.
CMAP.
Yeah, correct. But that's an axonopathy.
Yes, sir.
Yes, ma, continue.
And the treatment, in the treatment also, patient will be less responsive to IVIG, like in our patient, but he will be responsive to Plex, rituximab, and corticosteroids. Our patient is showing improvement after rituximab. And the radiology, usually there will be nerve root and plexus enlargement and enhancement. In the histology, that is nerve biopsy, we can see axonal degeneration, nodal widening, paranodal myelin detachment, no inflammation, or no segmental demyelination. In our patient also, there is no inflammation or no segmental demyelination. There are only axonal changes. So that is also favoring a nodoparanodopathy.
What was your histology report? Can you show that again?
Yes, sir. Axonal changes, sir.
They mentioned something else apart from that.
Chronic axonal neuropathy. The Hansen's disease, amyloid, sarcoid, and malignant infiltrative neuropathy, they have been excluded. And paraneoplastic is not excluded. Chronic axonal neuropathy. In the previous,
they have not mentioned anything about nodal paranodal changes in that bit which you sent.
Those were not mentioned, sir. Only in this report, axonal loss is present, but the fascicular architecture is preserved.
Right. Okay. Anything further?
That's it. Thank you.
Final
Allegation, sir.
diagnosis. What is the final
Yes, sir.
diagnosis? Is it a paranodal, is it a nodopathy, or is it a paraneoplastic CADP? I don't know, sir.
Sir, first I would like to consider paranodopathy, nodoparanodopathy, sir.
The patient already has a CA lung.
Yes, sir. Paraneoplastic CADP is second differential, sir, but it is mostly fitting into the picture of nodoparanodopathy, sir.
Is there a differentiating features?
Nodoparanodal, nodoparanodal, paraneoplastic. Is it like that?
No, sir.
What are the differentiating features between paraneoplastic neuropathy and paranodal neuropathy? And if you have anything.
Differentiating features, so usually in a paraneoplastic CIDP, usually there will be a typical classical picture will be present, and there is some associated cancer should be present within 5 years, sir. That is fitting.
What is the classical picture of a paraneoplastic?
Classical is not.
So, see, here the question is it paraneoplastic or paranodal? That is what was asked of you.
Yes, sir.
If you can't conclude, you'll have to say it's we are not definite.
We are not definite.
Is there any definite point for a nodopathy or paranodopathy without testing the neurofascin test clinical itself? Because
that's what
when
we
you have
have
already when you have a CA lung, then paraneoplastic CADP stands first. Without a neurofascin, how do you consider nodo or paranodopathy? Why can't you call it simply paraneoplastic CADP?
Yes.
You only will have to alter your differential diagnosis. Both are there. First priority will probably be paraneoplastic. Second possibility is paranodal, but you will have to wait for the antibody test.
And also the biopsy, sir, because it is not yet biopsy confirmed, sir. Only in the CECT it was showing carcinoma, sir.
Okay. Okay. And what about the response to rituximab?
If it is a
is there a difference in the response to rituximab?
If it is a paraneoplastic, the primary treatment should be treatment of the malignancy. Then only it will respond to anything else.
Okay, sir.
Sir, if we do the
when you say that patient
antibodies,
is not responding to steroids,
they have not confirmed the malignancy itself.
They have not ruled out a malignancy in a lung mass which is radiologically suspected to be a malignancy, sir. So in that case, then till it is ruled out, we will have to consider it as a malignancy. And if it is a CADP secondary to malignancy, the primary treatment will be to treat the malignancy only, sir.
Yeah.
All agreed to. Priyanka, but between paranodal and paraneoplastic, the response to rituximab is good in which one?
Paranodopathy, sir. Nodoparanodopathies.
Okay.
If you do the targeting antibodies, enough 155 or Casper antibody, then probably we will confirm the diagnosis.
Yes, sir.
So, but the problem of the nodopathy, paranodopathy again is this neurofascin false positivity is extremely high, sir. We do come across a lot of neurofascin positivity where we do not treat, sir. Out of 10,
is it from Chitrambalam? Is it from Amrita?
Yes, sir. Yes, sir. All only in India, I think only Amrita is doing it, sir. I would have out of 10, I treat only 1 or 2, sir. That is how it happens to be. In peripheral neuropathies, we do a neurofascin. If 10 patients show positive, in only 1 or 2, we very strongly consider paranodopathy and nodopathy. The false positivity seems to be very high, sir.
Also, Priyanka, you go for the biopsy of the chest lesion.
Because first, so in this case, I will first consider the paraneoplastic one, sir. And if it is a lung lesion, a cancer, then we should first treat the malignancy. Then only the CADP will respond.
Okay, sir. Once we'll
Sir,
proceed with biopsy, sir.
Sir Vijayan.
What about your oncologist opinion?
Sir, yes, sir.
Hello.
Oncologist query carcinoma, sir, but they have advised for the rebiopsy, sir. Because initial biopsy, the lesion was very small, so 2 by 2 centimeters. So the biopsy actually could not be obtained, and it was very close to some vessels, sir.
So what is the alternative he has given? Chemo cannot be started, no?
No, sir, they have advised rebiopsy from the lesion and can be started on injection.
Only it is confirmed. Till then, you have to wait and see.
Yes.
Will it not go further?
Vijayan, you wanted to say something?
Yes, sir. We are encountering a lot of nodopathy, paranodopathy of late. But one query to Dr. Chitrambalam. Sir, எத்தனை கேஸ் நீங்க பண்ணி எத்தனை கேஸ் பாசிட்டிவா வந்தது, எத்தனை கேஸ் ஃபால்ஸ் பாசிட்டிவா வந்தது, ஃபால்ஸ் பாசிட்டிவ்ல what were the symptoms?
Sir, for routine peripheral neuropathies, even without atypical symptoms, we have done. And many
Why
cases,
did you do, sir? Why did you do for routine peripheral neuropathy, sir?
அதுதான் நறுவி.
when we do not find any other cause, and when it is very severe, and when we come across even GBS,
documented peripheral neuropathy, sir. All these are documented peripheral neuropathy, sir.
Yes, documented peripheral neuropathy. Even GBS, we have the last case of GBS we did. There was, I think, NF 155 was positive. Rituximab was given. Then even then, the improvement was 0. His power continues to be 0 by 5 all 4 limbs even after 2 months of rituximab.
Sir, the only thing here in classical presentations like GBS can also occur with nodopathy and paranodopathy patterns.
Yes.
And there, obviously, the reason, because again, we had a debate recently in TAN. There were GBS, what to give, whether steroids or IVIG. Most of these polyradiculoneuropathies would prefer to treat with plasma exchange initially, wait for the reports of the paranodopathy, nodopathy panel, and if possible, maybe rituximab. So ideally, if there is a polyradiculoneuropathy, GBS or CIDP, nodopathy, paranodopathy panel is definitely useful. But before that, in all cases, it's better to always give treatment with plasma exchange first, at least 2 to 3 plasma exchanges, and then wait for the results, and based upon the results, continue. That was only sufficient.
Vijayan,
sir.
In GBS, what test would you do for nodal or paranodal neuropathy?
The same paranodopathy panel.
One minute. Do you mean to say that in all case presentations of AIDP,
yes,
we need to send a sample to Amrita?
Yes, sir. We have to.
That is, I think, nowhere
it is a must, sir.
Nowhere it is being done.
No, we don't do that.
We don't do that is different, sir.
Yes, sir. It should be done.
It should be done. It should be done.
At least in patients who do not sufficiently
it should be done. And two, sir, the point here is
in patients who do not improve, what you say may be true. But regular common and garden type of AIDPs where they respond to steroids or IVIG, there's no need for sending it for paranodal or nodal.
The point here to be noted is most of them, it is always wise to give them 2 to 3 plasma exchanges, wait for the results, and then based on the results of nodopathy, paranodopathy panel.
Yeah, but plasma exchanges are not done in many institutions because of the problems encountered those places. It is more cumbersome, so everybody resorts to IVIG.
Sir, veno-venous plasma exchange is a very safe procedure, sir, and we keep doing it regularly, sir. Yes.
Why don't you prefer rituximab?
No, sir. The first instance, obviously, in a case like classical GBS, rituximab may worsen the condition. So there we won't prefer.
You give steroids. The patient does not improve IVIG.
No, sir, we don't give steroids, sir. Nowadays we've changed the protocol. They always start with plasma exchange, unless if it is not feasible. For example, sometimes
it is not done. It is not in most of the places, Vijay, and I'm sorry to say that. Most of the places
Yeah,
they
that
go
is the
for
ideal way to treat a polyradical neuropathy. That was a submission it is an ideal way to treat a polyradical neuropathy.
Megan, sir.
Panel also, sir.
Vijay's
So we do
treatment is
ganglioside panel also. Ganglioside panel,
Yes,
then
yes.
if it's an
Of
IgG4,
course,
what
of course.
IgG4? Is it nodopathy, neuropathin also we do, sir. And
Yes,
the
sir.
patients who do not respond, by the time they do not respond, probably we have another set of tests to upgrade the treatment, sir. Either we'll have to go for a plasma exchange again, or we have to go for rituximab.
True, sir.
Yes,
I accept it.
okay, but if it is neurophasin antibodies, why do they not respond to plasma exchange?
They respond, sir. That is what. Most of them respond to plasma exchange rather than IVIG. Some of these paraneuropathies may be worsened by IVIG or steroids. That is the reason why in the ideal world situation, it is better to do a plasma exchange, 2 or 3, wait for the result, and then proceed based on the result.
Yeah, so that is Royal Care Vijayan's experience. That is what he is saying. We would have to follow it, or we would have to weigh the evidence and then decide. Am I right, Vijayan?
Yes.
Again, as Dr. Vijayan says, if you have started IVIG first, then doing a plasma exchange will take out all the IVIG also. So better to start with plasma exchange if
Yes, sir. Better
situation
to
is
start
good.
with plasma exchange and
Yes,
then
sir.
if
Yes, sir.
yeah.
Start with plasma exchange, then IVIG. That's what he is suggesting. But that
Yes.
seems to be practical also, sir, for the benefit of the patient. Yes,
I would suggest that the central institutions take up a randomized study of this particular aspect and come out with a protocol. They would have to do that and come out.
Sir, I tell, sir, we have had patients of positive nodopathy panel, neurophasin positivity, especially atypically presenting GBS patients, dramatically improving with rituximab and not responding to IVIG, sir. So we have seen, but so we have made it patients at least who do not show a substantial response. We always go for neurophasin, sir. And rituximab we give, sir.
Yeah, we have done rituximab and dramatic improvement we have seen, but we have not done the antibody study.
Yes,
but
sir. This rituximab we have tried only after doing the neurophasin tests, neurophasin antibodies, sir.
Yes, sir. Yes, sir. Agreed.
Yes, sir. Yes, sir.
No, we have not done that. But as Professor Vian pointed out, this plasma exchange becomes a very cumbersome procedure. Even
sir,
after
venous is a very easy procedure, sir. Very easy procedure.
They do it, but we don't get dramatic response out of it. Because after that, they immediately go for IVIG or rituximab. Most of the time, almost 80 to 90% after plasma exchange, we have not had any sort of a remarkable improvement after that. It has not replaced any treatment.
We need to have a study, sir. Let's have a study and decide. There are 2 more cases. Allegation, sir.
Yes, sir. We'll move on to. Thank you, Priyanka, for your wonderful presentation.
Thank you, Priyanka. Thank you.
Paraneuropathy. And move on to next case, case of paraparesis from Manoj. Manoj.
What happened? Everything has gone silent.
Just a minute, sir. Good morning, sir. Sorry for the delay.
Yes.
I'll be presenting about Mr. X, resident of Kotagiri, who was a drawing teacher by occupation. He had come with the chief complaints of difficulty walking for the past 9 years and tremulousness in both his hands.
Your slides are not visible.
Open the PowerPoint presentation. Yes.
Is it visible now, sir? Sorry, sir. I'll run through again, sir. My case today is Mr. X, who's a 59-year-old male, a drawing teacher by occupation from Nilgiris. He had presented the chief complaints of difficulty in walking for the past 9 years with the tremulousness in both hands for the past 2 years. Patient was normal 9 years ago when he first noticed weakness in the left lower limb, which was in the form of difficulty in getting up from squatting position, as well as in the difficulty in climbing up and down the stairs. He also experienced buckling of the knees. It was insidious in onset and gradually progressive. 1 year later, he noticed that there was slipping of slippers with awareness on his left leg. Simultaneously, he also developed buckling of the right knee with the difficulty in getting up from squatting the position, as well as climbing up and down the stairs. There was no history of slipping of slippers from the right leg, though. He gives history of flailness along with the thinning of both the limbs with the involuntary twitching more on the left leg. There was no history of any diurnal variation, no history of any weakness in the upper limb. There was no history of difficulty in gripping the objects or buttoning, unbuttoning the shirt, or reaching for the objects over above the head. There was no history of difficulty in lifting the neck off the pillow, but he's got history of difficulty in getting up from the bed and turning from side to side for the past 3 years. He was able to perceive his clothes, mosquito bites, and hot and cold sensation. There was no history of walking over the cotton wool. There was no history of giddiness or unsteadiness of the gait. No history of any visual disturbances or abnormal facial sensation or difficulty in chewing food. No history of loss of facial symmetry. No history of hard of hearing. No history of difficulty in swallowing or nasal regurgitation, hoarseness of voice. There was no history of any suggestive of cranial nerve involvement. He developed a history of tremulousness that is present in both the hands for the past 2 years. It was present in rest as well as in the while working. It was present more on the right hand. Stopped because of this tremulousness. He had to stop drawing for the past 1 year. He also developed tremulousness around his perioral region for the past 2 months. There was no history of slowness of activities. There was history of increased urinary frequency. With the urgency, with the difficulty in initiation, as well as occasional incomplete voiding was also present. There was no history of erectile dysfunction, palpitation, abnormal sweating. History of forgetfulness was present for the past 4 months. Misplacing objects was present, and there was one instance where he forgot the recent food he has taken. However, there are no history of forgetting the recent conversations. No other higher mental complaints were there. He was able to recognize all the relatives, interacts normally with them. No other history of any behavioral abnormalities like impulsive or rash behavior. No history of any wayfinding difficulty within or outside the houses. No history of hallucination, delusion, or illusion. No history of excessive cry or laughter. He does not go to the job for the past 2 years due to his disability. However, takes care of all the daily living by himself. One more history is the attendants have noticed that for the past 6 months, the volume of speech has gone down. However, he could comprehend whatever that was spoken to him. So the attendants had to ask him again, because his volume of speech was little less. Past history is a known hypertensive for the past 1 year. Personal history consumes mixed, no addictions. There are no similar history in the family. So summary, 59-year-old male, a known case of hypertension, is presented with the incidence asymmetric proximal onset plial motor weakness of the bilateral lower limbs with the trunk. There was hypovolemic speech, tremors of hand and jaw, human bladder involvement with recent memory loss without other cranial nerves, sensory and cerebellar deficits. So based on the structural localization, asymmetrical onset, flail weakness with the muscle twitching, be either in anterior horns versus bladder urgency with the frequency, hesitancy, and incomplete voiding. Suprasacral, I would like to localize it to the cord above sacrum and below pons. Hypovolemic speech with the perioral and hand tremors to the bilateral basal ganglia and its connection. And recent memory impairment, I would like to localize it to the medial temporal lobe. So based on the findings, I would like to, the differential diagnosis was like myeloradiculopathy. Was the first thing in view of the motor complaints as well as the bladder involvement. However, there are no significant sensory complaints for this patient. The patient had no sensory complaints at all. The other possibilities could be anterior horn cell with some early Parkinsonism. So based on this differential diagnosis, the further examination, the patient was awake, cooperative.
Why did you consider compressive first?
Sir?
Why did you consider compressive myelopathy as your
That was an asymmetrical onset, sir. It initially started in one limb, sir, and later on.
That's right. But it goes beyond the spinal cord, isn't it? Your presentation goes beyond the spinal cord.
Yes, sir. It's a multi-axial involvement is there.
So why compressive then? Anyway, continue. Doesn't matter. Continue.
On examination, the patient was awake, cooperative, obeying commands, and blood pressure was 130/80 in right arm supine position. There was no postural drop. And pulse rate was 80 per minute, regular in rhythm. There was no pallor ictus, clubbing, cyanosis, lymphadenopathy. There was dry, shiny skin was present in the lower limbs, the loss of hair. No other neurocutaneous markers were seen. CNS examination was educated till 10th standard. The Mini-Mental scale examination was 20/30. He had a deficit in recall. Only 2 out of 3, only 1 out of 3 could recall, and attention was also impaired. Was only 2 out of 5. And writing and copying also he couldn't do. The patient was appearance was normal, behavior was normal, level of consciousness was normal. He was right-handed, was present. TAPI test was impaired, and digit forward was 4 and digit backward was 3. Spontaneous speech was decreased with the fluency, both phonemic and semantic were decreased. Comprehension 1 step and 2 step he could do, and 3 step he was impaired. Naming of the body parts and color was intact. Repetition was normal. Reading was also normal. Writing was impaired. It was more of the impairment was second because of the tremulousness of the hand. No paraphasias, neologisms, and circumlocution was present. Memory, digit forward was 4, while digit backward was 3. Recent food intake on examination, he could recall actually. However, the recall of 3 objects at immediately post giving the object, he was able to do all the 3. But after at 1 minute, it was 2, and at 3 minutes, it was 1. It was not improving with the queuing. And the word associated learning as well as story recall was impaired, and visual memory, out of 5 hidden objects, he could identify only 3 and was not improving with cues. Remote memory was normal. Frontal lobe assessment, go, no go, and conflicting instructions, both were impaired, and fluency was decreased. Fist-edge palm test was also impaired. Luria was also impaired. Abstract thinking was also impaired. Intentional motor system also, there was persistence. The loop, he had put extra loop. Trial making test, trial A, he was able to do, but trial B, he couldn't do, but judgment was present. The parietal lobe, cortical sensations were normal. Line bisection and was normal, no hemi-neglect. Construction praxis was impaired. Both concept was also lost, and the shape also he missed it. Geographical praxis, clock drawing, he couldn't put the numbers inside the circle. And geographical praxis is also was present. He could reach the washroom correctly within the ward. Dominant parietal lobe, conceptual praxis, ideomotor, ideational, all were normal. Right to left orientation was also normal. Finger gnosis and was also normal. Simple calculation he was able to do. Complex calculation he was committing mistakes. Temporal lobe, recent verbal and visual memory were impaired, and remote semantic and personal events all were intact. Occipital lobe function, visual acuity was 20/30 in both eyes, and visual field was full on both sides. Both aperceptive and visual gnosis was normal, color vision was normal, simultagnosia was also normal, so no optic ataxia or visual disorientation. On cranial nerve examination, first all the cranial nerves are mostly normal except for the 12th cranial nerve, which had fasciculation with mild wasting on the sides. Rest of the bulbar cranial nerves were all normal. 8th, 9th, all were normal. Jaja was also not present. This is the video that shows the tongue fasciculations. It's sideways. He also has some chin tremors are also present. Will come out at me later. On the motor examination, the bulk upper arm it was 28 on the right and left it is 28. Forearm it was 23 and left it was 22.5. Thigh was also 40.5 on the right side and 40 on the left side. Calf was 28.5 centimeters on the right side and 29 centimeters on the left side. There was generalized wasting on the bilateral thigh and leg. And the tone was normal in the bilateral upper limb and flaccid in the bilateral lower limb. Power upper limb was 5/5. It was normal, including the small muscles of the hand. It was normal on the upper limb. On the lower limb, hip extensors, flexion was 3/5 on the both sides, and extension was 2/5 on both sides. Abduction, adduction were also 2/5 on both sides. Knee flexion was 4/5, 4+/5 on both sides, and extension was 2/5. And ankle, the dorsiflexion was 4+/5 on the right side and 3/5 on the left side. And plantar flexion was 4-5 on the both sides. And the EHR was good. As we can see, there's a differential weakness. The hip extensors were only 2/5, while ankle plantar flexion was 4/5 was present. This video shows that fasciculations we noticed in the calf muscle. Superficial reflexes were all present. Abdominal reflex was absent. Plantar was extensor on the right side, while on the left side it was flexor. Deep tendon reflexes, biceps was absent bilaterally. Triceps was just present. Supinator and knee jerk was absent on both sides, and ankle reflex was just present on the right side and absent on the left side.
Were they fasciculations or was it myokymia?
So fasciculations, sir, it was.
Okay. If you're convinced it's fasciculations, right?
Yes,
Fine.
yes. Glabellar torque was non-accommodating. Frontal release reflexes. Snout was present. Deep facial and palmamental were all absent, sir. Sensory was normal, and cerebellar signs were also not normal. No incoordination. Extrapyramidal, there was a hypomimic phase with a blink rate was around 11. There was no bradykinesia rigidity, but hypokinetic speech was present. And there was bilateral hand tremors, rest and postural was present. It was low amplitude, high frequency, and jaw tremors and the chin tremors were also present. This is the hypomimic phases with the re-emergent tongue tremors as well as the re-emergent chin tremors also he gets. That re-emergent chin tremors are also present. And he had it in the rest. Hand tremors are present both in hand as well as in posture. Gait was normal. Autonomic nerve system examination was normal. Spine and cranial nerve examination was also normal. Other system examinations were normal, sir, not contributory. So after examination, the localization was in higher mental, there was impaired attention, fluency, abstract thinking, and sequencing and working memory, which I would like to localize to bilateral dorsolateral prefrontal cortex, and impaired response inhibition, bilateral orbitofrontal cortex, impaired verbal and visual recent episodic memory, bilateral medial temporal lobe. There was jaw tremors, hypokinetic speech with the hand tremors also. I would like to localize them to bilateral basal ganglion nets connection, tongue wasting and fasciculation, that is 11th, 12th cranial nerve and nucleus. Flail lower limb paraparesis with the differential weakness and fasciculation, I would like to localize it. So after this thing, there was Parkinsonism with frontotemporal dementia. I would and MND, sir, ALS flail leg variant. There was Yellerman signs there was a wasting, tongue wasting in cervical as well as in the lumbosacral region, and also there was extensor plantar. So I would like to consider it ALS, probably flail leg variant, because there was no weakness in the upper limb.
C9 ORF 72 variation, isn't it?
Yes, sir. That is.
That's the first possibility.
That is the first possibility.
Right.
So the investigations, blood investigations were all normal, sir. We did viral markers were also normal. CPKT was 180 and CSF was also normal, sir. There were acellular with the normal protein and sugars. Ultrasound was also normal. The NCS showed bilateral lower limb, peroneal and tibial. There was axonal changes were present, sir. Motor, while sensory was normal, and F waves are also absent in the lower limbs. Sir. So bilateral lower limb motor axonal changes were there. And we did EMG. EMG, the spontaneous activity, there was fibrillation potentials were present, sir. And in the QMAP, there was large amplitude polyphasic potentials were coming. Large amplitude polyphasic potentials were coming with the reduced recruitment, and there was incomplete interference was also there. So the difference is better. So there was suggestive of neurogenic pattern. MRI brain with spine screening was done. There was atrophic changes. Volume loss was present in frontal as well as temporal lobe, along with the small vessel ischemic changes was also present. Sir. Spine, there was some mild disc disease was there, but however, there was no sign, no evidence of any compression anywhere. So the critical volume. Canal diameter was not in the critical level. So the final diagnosis was Guam complex, what we did, sir.
Guam, what? Did you do a genetic study?
Sir, we have planned, sir. It's been sent, sir.
Guam type is very specific, isn't it? Does it fit in with the Guam type?
Sir,
see, a lot of FTD with Parkinsonic amyotrophic features, we do study, but we do see, but necessarily they are not Guam. What are the differences between Guam and what we commonly see?
Guam generally presents with that lower limb, the most predominant phenotype. This was the first case report that was reported from case series reported from around 70 cases they have reported. In that, the predominant phenotype for MND is lower limb predominant flailness with some hyperreflexia. Distal SMA with hyperreflexia was a predominant motor this thing that was seen, sir. And it was the first symptom that was observed, sir, which later developed Parkinson's, and the dementic signs were cognitive impairment was the last one to notice, sir. So this case also had similar lower limb predominant involvement, any upper limb involvement. This was, and the progression was also almost for the average duration of the illness in that case series was 5 years, and the maximum progression they had was almost for 15 years.
What was the timeline in your case?
9 years.
No. Start of lower limb, then the upper limb, and then cognitive. What was the timeline?
My patient doesn't have any symptoms in the upper limb, sir. It's predominantly restricted to lower limb only, sir. Motor weakness is not there in the upper limb, sir. No wasting.
Okay. And cognitive involvement?
Cognitive involvement, now recently only, sir. For the past 4 months only, they are complaining of a recent memory disturbances. They are complaining, sir.
Manoj is a long-standing disease, 9 years duration, asymmetrical weakness of the lower limbs, perioral tremor, fasciculation, frontal lobe dysfunction. Wouldn't we think of a Kennedy syndrome, Kennedy disease?
Sir, Kennedy syndrome is also possible, sir. Sir, but other endocrine disturbances.
What about the cognitive issues in Kennedy?
They can have a frontal lobe dysfunction, sir. They can have a cognitive function impairment also.
With basal ganglionic features.
Other endocrine abnormalities are not seen, sir.
And basal ganglionic features?
Less likely.
They can have a tremor, sir. They can have a tremor. But even Manoj's case, the extrapyramidal is very minimally present, sir. It's not a marked symptom of.
No, if you look at his face.
Sir, predominantly perioral tremors and
jaw tremor.
Yes, sir. And tremors, sir. And hypoemic phases is there. Hello, sir. Hello?
Anybody else have anything else to say, please?
The bladder involvement, do you think it is because of the dementia?
Sir, there was no disinhibition, sir. He was completely aware and there was no episode of any disinhibition. Maturation in inappropriate places was not present.
There was no prostatic hypertrophy?
Yes, sir. Ultrasound was normal, sir. Prostate.
But the bladder involvement is significant. Says that
yes, sir.
Not able to control and does
yes,
he
sir.
have incontinence?
Yes, sir. He has incontinence, sir. He has the frequency has also increased and he has clear difficulty in initiating also, sir.
Which is against ALS, isn't it?
Yes, sir. There is which is like against ALS, sir. That's
not with the frontotemporal.
There's one article we had a bladder which found in possible reasons where bladder involvement could seem in anterior consult we saw, sir. First common cause of bladder is functional incontinence, sir, in late stages because of the patient's mobility issues, and ALS FTD present with frontal disinhibition can give rise to bladder complaints, sir. And ALS plus syndrome with the Parkinsonism especially, they may have bladder involvement because of autonomic dysfunction. However, our patient didn't have any other signs suggestive of bladder involvement, sir. Or autonomic dysfunction, sir. The last rare thing which is seen in our patients is a true neurogenic bladder. There, the detrusor overactivity dyskinesia can happen because of possible some mild human involvement in the sacral pathways. This is one that has been postulated in that article I found, sir, online.
He has no pyramidal signs.
Extensor plantar is there, sir. On the right side, there is an extensor plantar.
The duration of the illness, sir, it's a 9-year duration. Yeah, frontotemporal combination lasting for 9 years.
Both are usually mild features, no? FTD and ALS. It's not a florid ALS-like presentation. So it usually goes on for 6 years. I don't know about 9 years. 5 to 6 years, yes. Seen that. Again, we'll have to depend on genetic study.
He doesn't have any sort of bulbar symptoms like difficulty.
No bulbar signs, sir.
And it has stopped with that. It has stopped with the lower limbs and has gone to the.
No, Manoj, he has got tongue fasciculation means bulbar.
Truncal weakness has also developed, sir. bulbar, sorry, sir, bulbar tongue wasting effects, but he has not developed any dysphagia or hoarseness of voice is not there. Nasal regurgitation is not there.
Suppose we are planning for a genetic studies, which study we are going to do?
Sir, we have sent, we've searched a few articles, sir. The recent, in the literature, the most common cause for Guam was actually environmental, sir, because of that BMAA.
This is not Guam. This is not. This is our own.
Yes, sir.
What you have to do is you have
in Japan, they have a Muro. In Japan, they have a Muro disease similar to Guam's.
Yes, sir. From Key Islands, they have reported similar.
So probably from India, what is it?
You will have to do C9ORF, ma. That's the most likely. C9ORF72 is most likely.
C9ORF72 and SMN also we are because the phenotype also have predominantly was found as spinobulbar.
Where are you getting it done?
Sir,
where do they do C9ORF2?
Sir, this will come on the whole exam, sir.
Whole exam.
Okay.
Yes, sir. Yes, sir.
Okay. Sir. Yes, Ramkishan, go ahead, please.
Sir, C9ORF, I don't think it comes under whole exome, sir. But they are doing it separately in medgenome, nenikrang, sir. Now, whole exome la varadung, sir.
Oh, sir.
Okay.
எப்படி என்ன செப்பரேட்டா என்ன கேட்கணுங்க அப்ப?
C9ORF தான் கேட்கணுங்க சார். ஏன்னா அது வந்து குரோமோசோமல் இது இல்லீங்களா, ஓபன் ரீடிங் ஃப்ரேம் டிஃபெக்ட்ங்க சார். ஹோல் எக்ஸாம்ல வராதுங்க சார்.
ஓகே சரி.
ரிப்பீட் எக்ஸ்பான்ஷன் தான வராதா?
அது மாதிரி தான் டெக்னாலஜின்னு நினைக்கிறேங்க. ஆனா அது மட்டும் கன்ஃபார்ம் பண்ணிக்கணும்.
சிஏஜி ரிப்பீட் எக்ஸ்பான்ஷன் சேர்ந்து தான வரும்.
அதுல தான்
சார் அது வராது. ரிப்பீட் வந்து ஹோல் எக்ஸாம் வராது சார்.
எனக்கு சேர்த்து வரலாம்.
ஆமா சார். வராது.
Oh. So note it, pa. You will have to do like that.
Okay,
medgenome le pannalandraru.
Yes, sir. We sent it to medgenome only, sir. Under scheme, it has been sent, sir.
Okay.
The patient was treated early. The Parkinson's feature, we treated him with the levodopa and triaxiphenidil, sir.
There might be some objections to triaxiphenidil, particularly with memory disturbance.
So at the time of his discharge.
How was he when he was admitted? Was he ambulant to this extent?
No, sir. There is some very minimal improvement is there, sir. Not much, sir. Because some tremors and all have come down. Not much improvement is there.
Okay. Right, that's good. Thank you.
Yes.
So very likely C9ORF72, possibly.
So, but when we do a whole exam, other genes will be covered like a third one and others.
Thank you, Manoj, for our wonderful presentation. It's a very interesting case. We will move on to last case.
Thank you, sir.
A short case.
A case of rare variant of muscular dystrophy by Shivani.
Yeah, we seem to have had the whole spectrum of neurological disorder.
So myself, Shivani, I'm presenting a case of a variant of a muscular dystrophy. So the proband was a 25-year-old male who was educated until BSc Computer Science. He presented with the chief complaint of tripping of toes and bilateral upper limb weakness since 15 years of age. So coming on to the presenting illness, the patient was apparently normal until 7 years of age, where he noticed difficulty in blowing his cheeks and whistling. 3 years later, his parents noticed that he was not closing his eyelids tightly while sleeping. 4 years later, he developed tripping of toes, initially in his right lower limb, which was followed by the tripping of toes in his left lower limb 6 months later. Simultaneously, he developed bilateral upper limb weakness in the form of difficulty in combing hair. And 3 years later, he developed a difficulty in getting up from squatting position. This weakness was associated with flareness of limbs. So coming on to the timeline, at 7 years of age, the first complaint they noticed was difficulty in whistling. Followed by that, at 10 years of age, the parents have noticed that there was a difficulty in closing eyelids tightly. And at 15 years of age, they have noticed that he was tripping. There was some tripping of toes in his right lower limb, followed 6 months later by tripping of his left lower limb. At 18 years of age, they have noticed that he's having difficulty in getting up from squatting position. And since 15 years of age, the motor weakness has been progressing, such that at the time of presentation, the patient needs some minimal assistance to perform his activities of daily living. However, this weakness was not associated with any stiffness. There is no abnormal muscle twitching. There is no history of any muscle cramps, and there is no history of diurnal variation or worsening with exercise. And there is also no difficulty in releasing objects from grip, and there is no history of passage of dark colored urine. There is no history of numbness, or there is no history of any sensory disturbances. There is no history of difficulty in navigating narrow pathways, and there is no history of visual disturbances. And there is no history of difficulty in marshalling of food or swallowing difficulty, and there is no history of any bowel and bladder disturbances. Coming on to the past history, the patient had a history of frequent respiratory infections in his childhood, and at about 12 years of age, he was diagnosed as a restrictive lung disease. There is, however, no history of any diabetes mellitus or any pulmonary tuberculosis. Personal history, he consumes mixed diet. And coming on to the birth and the developmental history, he is born at term via normal vaginal delivery, and he is born of a non-consanguineous parentage, and his developmental milestones were normal. And family history, the proband has one younger sibling, is normal, and there is no history of any similar complaints in the family. So to summarize the case, the proband is a 25-year-old male who presented with insidious onset and gradually progressive facial weakness and asymmetrical onset of pure motor flaccid limb weakness. It is distal predominant in the lower limb and proximal in the upper limb, without any sensory, cerebellar, extrapyramidal, autonomic, bowel and bladder involvement, and without any significant family history. So with this history, our localization, it's an element kind of a weakness. So we have our localization consists of two structures. It's either a muscle or an anterior Honsel disease. So the points which are favoring a muscle include a pure motor weakness and flaccidity. However, the points against the muscle are the asymmetrical onset of lower limb distal weakness. And similarly, in the muscle, the differential diagnosis that we could think of include an FSHD or otherwise an LGMD. And the points in favoring an FSHD include an asymmetrical onset of distal lower limb weakness as well as the facial weakness. However, there is bilateral upper as well as lower limb involvement. Those are the point. That is the one point which is against an FSHD. However, let us confirm. We can with the further. Let us see what it might be. And coming on to the LGMD, there is a proximal upper limb as well as a lower limb involvement as well. That is the one point which is in favoring the LGMD. However, the facial involvement and the asymmetrical onset of distal lower limb involvement are the points which are against an LGMD. And coming on to the anterior Honsel. So the pure motor and the flail kind of a weakness are the points which are favoring anterior Honsel, especially a type 4 of an SMA, because the age of onset is at 7 years of age. However, there are no fasciculations as per the history, and the wasting more than the weakness kind of a pattern is not seen in this patient. So those are the points which are against an anterior Honsel disease. So with this history, let us look at the examination of the patient. Upon examination, the patient was conscious, oriented, and afebrile. His vitals were stable, and there were no neurocutaneous markers. Upon examination of the higher mental function, the patient is a right-handed individual. He is oriented to time, place, and person. His speech and language was normal, and his MMSE was 30/30. Now, coming on to the examination of the cranial nerves, we have noticed that there is a bilateral orbicularis oculi weakness as well as bilateral buccinator weakness, as evidenced by difficulty in whistling. Rest of his cranial nerve examination was within normal limits. Now, coming on to the spinal motor examination.
Which muscle?
So, buccinator, sir.
Right, orbicularis oris.
Okay, sir. Oris as well as buccinator. Okay. Now, coming on to the spinomotor examination, looking at his bulk, we have noticed that there was a wasting in the anterior as well as the posterior fibers of the deltoid, as well as some subtle biceps weakness was noted. Biceps wasting was noted, and polyhill sign was noted bilaterally, as evidenced as you were able to look at the image. And there was a bilateral scapular winging. The scapular winging was symmetrical.
There is also gynecomastia?
No, sir. There was no. No, sir. There was no gynecomastia. Coming on to the motor examination of upper limbs, the tone was decreased in all four limbs, and coming on to the motor power of the bilateral upper limbs, at the shoulder girdle, abduction, adduction, flexion, extension, internal as well as external rotation were all 2/5 bilaterally. At the elbow, the flexion and extension were 3/5 bilaterally. At the wrist, the flexion and the extension were 5/5 bilaterally, and the hand, the power of the intrinsic muscles of the hand was normal bilaterally. And coming on to the examination of the neck, the flexion, neck flexors were weak, however, the extensors were good. Coming on to the lower limb motor examination, we have noted that there was a bilateral EDB hypertrophy bilaterally, as well as there was a bilateral calf atrophy. Coming on to the power examination of the bilateral lower limbs, at the level of the hip, the abductors and the adductors, the power was 3/5 bilaterally. However, there was a slight asymmetry in the power of the adductors and the abductors and the flexors and the extensors. The flexors and the extensors were slightly more weak, with a power of about 2/5. At the knee, the flexion and the flexors and the extensors were, the power was about 4/5. And at the ankle, the dorsiflexion was about 1/5. The plantar flexion was about 2/5. The inverters and the everters were also weak. Coming on to the examination of the reflexes, all the reflexes were absent except for the knee jerk bilaterally, which was about 2+. So reflexes were present, not completely absent. Knee jerk was present. And the plantar reflex was, the plantars were flexors bilaterally. Coming on to other examination, the fatigability test was negative. Beaver sign was negative, and the sensory system examination was normal. Cerebellum examination was also normal. The spine and the cranium, we have noticed that there was an exaggerated lumbar lordosis, and other systemic examination was within normal limits. So coming on to the gait examination. So as you are able to make out, the patient is having a bilateral foot drop and he is having a high step page kind of a gait. And he has a difficulty in getting up from squatting position because of hip girdle weakness. So to summarize, he's a 25-year-old male who presented with insidious onset and gradually progressive, asymmetrical onset, pure motor flaccid weakness, and the pattern of weakness is facioscapuloperoneal pattern and without any significant family history. So after the examination also, our structural localization is the same. It can either be a muzzle or an anterior hornsel. The points favoring the muzzle include the pure motor weakness as well as the flaccidity. In the muzzle, the differential is an FSHD in view of the asymmetrical onset of foot drop as well as the facioscapuloperoneal pattern. However, there are certain points which are not favoring an FSHD, like the absence of a beaver sign. Usually, beaver sign is seen in about 90% of patients with an FSHD. But even then, the first differential should be an FSHD for the patient. Maybe it's somewhat like an atypical FSHD that we can keep in mind. Coming on to LGMD, calpainopathies will also have a similar kind of weakness with a bilateral scapular winging is the one point which is very much in favor of it. However, the absence of we cannot explain the facial weakness in the patient with a calpainopathy. Similarly, dysferlinopathy also is one of the differential in view of the predominant distal lower limb weakness as well as the bilateral scapular winging. And the points which are favoring the anterior horns will include the pure motor weakness as well as the flailless. However, we have not noticed any fasciculations or the wasting more than the weakness pattern in this patient. So the weakness was only more. So that is one point which is against the anterior horns. So with this differentials, let us look at the investigations of the patient. So the hemoglobin was 14.3. The WBC count, platelets, RFT, LFT, serum electrolytes were all within normal limits. ESR was about 15 mm per hour, and the serum CPK was 2160, which is about 10 times the upper limit of normal. And the 2D echo was also normal, and the chest CT showed features which are suggestive of a restrictive lung disease. And the NCS of all 4 limbs was within normal limits. So we proceeded further with an EMG. So in the EMG, we have noticed large amplitude polyphasic MUAPs. Sorry. With an incomplete recruitment. So this was actually, it was showing a neurogenic pattern on an EMG. Our first differential diagnosis in this patient was an FSHD. But after we found a neurogenic pattern on an EMG, we did some literature search, whether any atypical findings are there. There are certain red flags in this patient for an FSHD, like the absence of a Beaver sign, which is usually seen in about 90% of the patients. It's not a hard and fast rule that it should be there, but its absence and the neurogenic pattern also made us think in maybe something else is there that we just wanted to rule out. And the serum CPK also, there is one red flag that usually in an FSHD, it will be about 5 times the upper limit of normal. In our patient, it is about 10 times the upper limit of normal. In view of this, we did some literature search. So in this, what we found was there was one case report wherein the patient had an overlap of an FSHD as well as a calpain-3 gene mutation. So this is one thing which can explain all the atypical findings of, and nowadays a lot of people are having double genetic mutations. So that is one possibility which can explain the whole constellation of findings in this patient. Another thing is usually the traditional thinking is that facial weakness will not be seen in LGMD patients. However, there are multiple case reports which are showing that facial weakness can be seen in heterozygous carriers of calpain-3 gene mutation patients. Similarly, there was one dysferlinopathy also. Usually facial weakness is rare. There is one recently, in 2016, there was one article which looked at dysferlinopathy patients. It was done in USA, wherein they found that facial weakness can be seen in about 3% of patients with dysferlinopathy. So usually the myopathies which present with the traditional thinking is that the myopathies which can have facial weakness is myotonic dystrophy or an FSHD. However, sometimes rarely dysferlinopathies or calpainopathies can also rarely, they are very atypical presentations, but one needs to keep that in mind. We just want that point. And similarly, there are certain subtypes of SMA. Type 4 SMA, they are called as the scapuloperoneal muscular atrophy syndromes, which are due to mutations in the TRPV4 genes. They can present with a scapuloperoneal pattern of weakness. So before labeling them as some myotonic, as some muscular dystrophies which are untreatable, we have to rule out these scapuloperoneal syndromes also. That's what we just wanted to highlight regarding these things. And actually for the further workup, our first differential in this patient still remains an FSHD only. Maybe it's an atypical FSHD. we have, for the further investigation, we have sent the whole exome sequencing for the patient, sir. And the report is awaited.
Whole exome sequencing, will it cover the genes
No,
for
sir.
FSHD?
No, sir. We have to do a southern blotting in view of the
They do what is called
financial-
optical genome mapping in MedGenome. They specifically do a optical genome mapping.
Okay, sir. We'll try to send it, sir. Actually, because of financial constraints, we were not able to
This
send
optical
it.
genome mapping is charged very high. Even for the concern, most concern rate is around 75,000.
Yes,
60,000 you can bargain,
Yes.
and the
Yes, sir.
corporates, they do it for more than 1.2 lakhs.
Yes, sir. In view of that only, we just wanted to rule out whole exome. At least it will cover few of the genes for the SMA and LGMD, also few of the genes that will be covered. We were like, we'll rule those out first, then we'll counsel further for southern blot.
Shivani,
Yes, sir.
your differential diagnosis is LGMD for facioscapulohumeral, right? But how do you explain the neurogenic findings on EMG with LGMD?
Sir, LGMD I cannot explain, sir.
That was your main objection for facioscapulohumeral.
Yes, sir.
Forget the Beaver sign. Beaver sign is of all of late. Before
Yes,
that, we have not looked at Beaver sign. 10 years or 15 years ago, we were not looking at Beaver sign.
Yes,
So, your main objection was it showed neurogenic pattern. The
Yes,
same
sir.
objection remains for LGMD
For
also.
LGMD as well, sir.
Yes.
Anterior hornsel, it can happen, sir. So I was just talking about
So,
differential.
in other words, if you want to differentiate SMA, maybe yes. But SMA
Yes,
with such amount of involvement and with a CK of 2000 plus, again, it's a red flag.
Sir, actually, type 4 in the specific scapuloperoneal syndromes up to 10 times, sir. But even with that, our patient, it is 2160. That is slightly.
No, I am talking of SMAs.
Yes, sir. Until 10 times normal can be seen in SMEs was what the literature search was. I was able to.
You mean
SMEs, sir, up to 10 times.
9,000 up to 9,000?
No, sir, up to 2000, sir. Even then, that is a red flag, sir. It is 2116 our patient.
Yeah, red flag for what?
Red flag for anterior hornsel, sir.
Yeah, that's what I'm saying. It's very unlikely for SMAs.
Yes,
See,
sir.
the values may be there, but you would have seen so many SMAs and you would have done CPKs. Seldom
sir.
do they go about this level.
Yes, sir. Actually, in the FSHD itself, sometimes we can get a neurogenic pattern. That also some literature is there, sir. We just wanted to highlight
Yes,
that.
yes, FSHD can have inflammatory.
Yes, sir. Inflammatory
Like
changes
inflammatory
can happen.
muscles.
But there should be myopathic changes, isn't it, Chitramalam?
Yes, sir.
You might find a spontaneous activity, but basically the EMG should be myopathic.
Yes, sir.
The
that is
potential
what-
should be myopathic. You might have spontaneous activity.
Yes, sir.
Yes, sir. That is what it's a little unusual, sir. We were also not able to.
But still, clinically, it will be FSH.
Clinically, it is FSHD, sir.
Yes.
So clinically,
Until
and
proven
CPK
otherwise.
wise, it's fitting with muscular dystrophy.
Yes, sir.
I did for one patient in March 2024, sir. The gene was 4Q35 bar 4QA autosomal dominant pattern, sir.
What does that mean?
That is pathogenic. Pathogenic repeat contractions of 4QA permissive allele detected in repeat counts. That's what that's what they
No,
do.
but
sir. They
what would
do
the
optical-
diagnosis be?
FSHD, sir.
Oh, thank you. Right.
That is a little costlier one, sir. That is why we don't routinely do, sir. 75,000 minimum, sir.
We clinicians depend on clinical findings.
But most of them have beavers, sir. Most of the patients where we finally prove
Mike,
FSHD beavers.
how many patients of FSHD we have seen, and in how many have we seen beavers? We are looking at beavers only for the last few years, not
sir.
before that. Maybe 15 years, not before
Yes,
that.
sir.
So we don't know. No, I don't think beavers is a sine qua non to say that it is FSHD. What Meghandan sir, you
When we
and
think about
Ramakrishnan,
muscle,
Meghandan
when we
and
think about
Ramakrishnan, you see more of FSHDs.
when we
Would you
think
say
about
that beavers is a must?
That's what we are. That's what we are surprised. We FSHD with neurogenic pattern like this, and
No, forget that. What about beaver sign? Have you looked at
We-
beaver sign in FSH?
No,
Is
we
it mandatory?
don't, sir.
Is it
No,
mandatory?
sir. No, we probably for a few years they give importance to that. Probably
Before that, we have not looked at it.
we were not looking for that also at all.
The
I don't know.
D4 Z4 loci is the one, sir. The D4 Z4 locus. That is the
Ramki,
catching one. But whenever we think about muscles and we have a beaver sign, we take it for
yeah,
granted.
that is
it
true. That is
FSHD.
true. That is true. The
Yeah.
reverse is true. The
And
reverse is
that
true.
importance is given only nowadays, sir. And
When you
again,
have it, you know that it is there. But you don't have it, I don't think it excludes FSHD. Ramkrishnan, what do you say?
எஸ் சார் ஏன்னா எஃப்எஸ்ஹெச்டியே நம்ம ரொம்ப ரேரா தான் பாக்குறோம் சார் அண்ட் ஜெனட்டிக்கலி கன்ஃபர்ம்டு எதுவுமே இல்லைங்க சார். சோ ஃபார் ஐ am
Yeah, what about beaver sign
Sir,
and
we
FSHD?
see in West Bengal and Bangladeshi patients, all the FSHD I have seen are from Bengal speaking patients. I have not seen one Tamil speaking patient in our hospital, sir. So some
the
4
Bengal
patients we have come
people, they
across.
start coming towards now south most of the times. For corporate hospitals, they come and they want to get it confirmed. And what about contractures and any
There were no
contractures?
contractures.
No, no.
There were no contractures, sir.
Ramkrishnan,
Because,
you were saying something about beaver sign and FSHD. What did you say?
சார் பீவர் சைன் நம்ம பார்த்த கொஞ்சம் பேஷண்ட்ல எதுலயுமே பீவர் சைன் நான் பார்க்கலீங்க சார். ஐ
Okay.
நாட் ஃபவுண்ட் அவுட் சார்.
Thank you.
தேங்க்யூ சார்.
So experience varies.
So the last patient, the genetically proven patient also, the suspicion of FSHD was confirmed clinically by beavers. Then we did the optical genome mapping that showed the D4 Z4 locus gene positivity. sir.
Chitrambalam irundaduna, yes, it helps in the diagnosis. Illena,
Yes, sir.
it does not mean FSHD is not there. That is what we are saying.
Yes, it's a little against. I would rather say absence of beavers is a little against FSHD diagnosis in a suspected case of muscle involvement, sir.
I don't know.
What,
See,
what is the importance, sir? How do they
only thing,
correlate?
as a differential involvement, Meganan sir.
Differential
It
involvement
shows
is
only a
abdominal
differential
muscles.
involvement. அவ்வளவுதான். Lower
Yes, sir.
fibers are more involved than the upper fibers of the abdominal. அதெல்லாம்
Yes,
எவ்வளவு
sir.
தூரம் I don't know.
But very
Shivani.
useful, sir,
தெரியாம
clinically.
பேசக்கூடாது.
Clinically very useful, sir, for suspect
அப்பா
FSHD.
இருந்ததுன்னா எஸ்வா இருந்ததுன்னா
Yes,
யூஸ்ஃபுல்
sir.
யா இல்லைன்னா இல்ல. Several times we talk of something is not being there. Not being
So the
it
problem
is
of
being, if
FSHD
it is
is
there, it is
we
helpful.
don't do the genetic confirmatory test because of the cost. It doesn't come under whole exome. That is why we experience of FSHD is a
Appa,
little
other
limited.
features are fitting with FSHD. But what is your differential? In which differential do you get these sort of features? சொல்லுங்க.
Yes, sir. That's what they have presented. LGMD with rare calpinopathies and others. But
அப்பா
until proved
calpainopathy
otherwise, it's
neurogenic
FSHD.
வராது neurogenic and also neurogenic
Yes, sir.
வராது.
Yes, sir.
So
So
ஒரு
this is until
feature
proved
ஒரு
otherwise, it is
feature இருக்கு ஒரு
FSHD, sir.
feature இல்ல.
Shivani,
Yes, sir.
Yes, sir.
and your case clinical phenotype and CPK fitting with limb girdle muscular dystrophy. But DMG is neurogenic. And you have
Yes,
sent a genetic test.
Actually, the
exome
serum
sequencing.
yes, sir. Serum CPK also, it is 2000. That is also a little unusual for an FSHD patient, sir. Usually more than 1000.
Ma, எந்த LGMD ல you have so much of facial weakness, Amma? Tell me
Sir,
that.
nothing else, sir. Nothing else will have this much of facial weakness.
Then why are we discussing something which does fit in and going
But
for
you-
extraneous diagnosis?
You have already sent a whole exam sequencing.
Yes, sir.
If
Whole
the
exam
report,
only.
if the report comes as negative, what will you do further?
Sir, further we can plan for southern blotting, sir, for FSHD.
Southern blotting for what?
Southern blotting for
Why don't
FSHD.
you, why don't you plan for muscle biopsy?
Okay, sir. We were just.
Sir, I don't think muscle biopsy will be of much use because it's again an
Muscle
invasive
biopsy
test.
does not help. How will muscle
Yes,
biopsy
sir.
help?
It may not help and it is invasive also.
Shivani,
Yes, sir.
for facioscapulohumeral, would you put them on corticosteroids? That is what would be the next question.
No, sir.
No deflazacort for FSHD?
Sir, I couldn't get you.
No. Do you put them like Duchenne dystrophy? Do you put them on corticosteroids? FSHD? What Ramkrishnan Meganan says? What do you say?
No, sir. No, sir. We don't give.
No, sir, I haven't used, sir. No,
We
sir.
are using only for DMD, sir.
Yes, sir.
DMDs.
Yes, yes, Shivani, you will have to continue or conclude, whichever way you want.
Sir, we are further, we're just waiting for the report, sir. Even now, our the first differential is FSHD, sir. Clinical, it's always better to go by the clinical. We are thinking in terms of FSHD only. We are just, we just wanted to rule out the other things because it's exorbitantly
We have
priced.
to look for the family history again and again.
Ma, what other things you want to rule out, ma? What other differential you want to rule out?
Sir, anterior horn cell is one thing, sir, that I want to rule out.
What anterior horn cell you are? How are you going to rule out?
SME, scapuloperoneal syndrome, sir.
No, how are you going to rule out?
Sir, whole exome, a few of the genetics will be covered in the whole exome, sir, for the anterior horn cell disorders.
What SMA4 SMA is going to be covered, is it?
Yes, sir. Certain things will be covered in the.
Okay, and having found out, what are you going to do?
Sir, because it is treatable, sir. It is potentially treatable. We can.
What SMA is treatable? I mean, this sort of SMA.
The recent drug, they say, no? The recent drug, what is that? Risperidone now.
Sir, we should not take, I mean, that is for which SMA and at what age and how far. It's all in the experiment. I mean, I wouldn't say experimental. It's still being tried out.
Yes, sir.
Yeah, it has come to the market, sir.
Yeah, that is true. That doesn't mean we'll have to go all out and look at whole exome sequencing for SMAs in all patients. I don't know. There is a lot of differences in our views. There seems to be a lot of differences in our views. Yeah, and the cost also. Now, of course, NATCO has come with a lesser cost, but we need to see what are the conditions, what are the specifics for putting them on treatment, which sort of SMAs do respond. All of that we need to go into.
Yes, sir.
You have to take a good pedigree chart and find out at least minimal weakness or facial weakness. FSH, we have got several cases where very strong family history. Unlike a simple mutation of a single case, I think you have to go into the family history further, which may give us a clue that it is FSH.
Okay, sir. Actually, we have examined the brother also, sir. He was not having a.
You can see the father, brother, and uncle, the first generation, second generation. You can take a sort of call as many people as possible, put a very good pedigree chart, and find out any minimal weakness or facial weakness, something different type of manifestation. That will give us a very strong clue that we are dealing with a type of FSH, because that's a very strongly positive in FSH cases.
Yes, sir. We'll try to do that, sir. Thank you, sir.
I thank all the presenters and the faculties of Coimbatore Medical College Department of Neurology for presenting excellent cases.
And the discussants also, including the chair, the moderator, Dr. Shobana, the chair, Dr. Alagasan, and all the discussants who have taken part in the discussion so passionately.
Congratulations for the 50th session, sir. Professor
Congratulations to whom? To all the neurology faculties.
Especially for you, sir.
Sir, I am doing nothing. I am just coordinating. You people present, you people discuss.
Encouragement and support always.
As I said, you are the encouragement and support for having this program going on. You all are doing it. Right. Thank you, ma. Anyway, thank you so much. Thank you so much.
Thank you, sir.
That all very nice cases, very nice discussions. Thank you. And compliments to all the presenters. They did a good job. Good presentations and discussion by them.
And the first case was extraordinarily
Yes.
Yes, sir.
That's right.
Yes, sir.
First case was very good. And Sankavi did a very good job presenting and discussing also. Yes, sir. Alagasan, sir, it's up to you now. You are not audible, sir. Alagasan, sir, you are not audible.
Thank you all for participating in this clinical forum, sir. It's a wonderful program. I think I will close the session, sir.
Yeah,
Thank
and
you.
as usual, thanks a lot to Sun Pharma for continuing to have this program. And next month, we will have from Chengalpet Medical College, Department of Neurology from Chengalpet Medical College. We'll be presenting on that. Will be on the 30th of November.
Okay, sir.
Thank you. Thank you all.
Thank you, sir.
Thank you so much, ma. Thank you, ma. Thank you, Shobana. Very good cases. Dinesh, can we leave?
Yes, sir. Yes, sir.
Closing down? Okay.
Yes, sir.
Thank everybody. Thank all the participants. Thank you very much. Thank you,
Thank you.
Dinesh.
Thank you. Thank you.
Thank you.